inside.
You'd like to talk about was VR devices, like projection devices. But from my knowledge, I believe VR devices are considered very bad for vision. So how come they not be affected by VR devices on that way?
The low VR is already everything is done. The damage is done. Whatever is there, whatever is the possible way, we have to make that better. So just suppose they are using so many other devices and so that they not able to see. So if with the help of VR, we are making the things more bigger, they are able to see. So that is better for them, so that we can able to beat that.
Thank you so much, sir, for your inspirational talk. We learned a lot. Thank you.
Thank you so much, ma'am.
Now, the next special talk is from the Medical Lab Science Department, from Mr. K.S. Rana. Mr. K.S. Rana is working as head of the department in the Department of Medical Lab Science, University School of Allied Health Science. Mr. K.S. Rana has 35 years of clinical as well as teaching experience. He has worked in Chandigarh University for at least 4 years as associate professor. He postgraduated in pathology with hematology as special subject from PGI-MER Chandigarh. He has 30 national and international journal publications. I request you, sir, to come on the stage and share some thoughts.
Good morning. Good morning to everybody. My topic is organ transplantation overview. So first of all, what is organ transplantations? That is the replacement of diseased organs of the body by the normal. So this previous time it is known as the organ transplanters, but nowadays it is organs, tissue, or the cell. Any kind of this we can replace for the benefit of the recipient who is suffering from some disease. So this is the historical aspect. Actually, this was, if you go to some previous history, 600 years BC, this system was there, but there was a dormant period, and nowadays this research is going on and giving us a better result. So this is the history. In 1954, first transplantation of kidney takes place, then kidney and pancreas in 66, 67 successful transplantation takes place of the liver.
Hello.
68 pancreas isolated and transplantation at successful of heart transplantation next year. So 77 there is digital formations takes place and it is attached with that. So whatever there is kidney or the organs transplantation was there, that is automatically attached with and needy person can get it. 81 heart and lung transplantation takes place. Then there was rejection rate was high at that time. So 83 cyclosporin was is at it gave us good result. So these are the various organizations, ROTO, LOTO, that is state level, then national level, then at the global level, so that you can know the availability of these organs and be given to the needy person at the specific places. Next. Next. Double lung transplantation was 86. Intestine plantation was held at 7. And as I told you, tissue that liver, if it is circulated, some part of this is transplanted, it is also successful. Next. So then previous time it was the history that only the living person can donate organs to the deceased, but ultimately from 2001 that a person who is brain dead means his brain is dead but still taking the breath. So sometime when there was a constant formation, some system is there and they recognize that a person who is brain dead can also donate the organ to the needy person. In 2021, 40,000 transplantations in a single year was that successful in USA and 22 1 million transplantations in USA. India is in third position in this as compared to the other country. Next, please. And this is the type of transplantation. What is autologous? That is on-circuit transplanted. Next is allogeneic cells from the other person, that is brother, sister, father, mother. Next. This is another, that is the cell transplantation I told you earlier, that is the bone marrow transplantation. And when it was started many years back, at that time was also the associated with this process. So it is the peripheral blood previous time that is very problematically, but nowadays this bone marrow transplanters is taken by the FSS, which is by machine, and the donors fitted with that machine, blood or bone marrow is circulated, only the stem cell is taken and given to the patient or the needy patient. Next, please. This allogenic, as I told you, at success rate is 25%. That is the out of 4, 1 is successful, or you can donate it. The procedure is that I told you that. So bone marrow transplantation is done to treat number of cancerous or non-cancerous cases. Cancerous cases, leukemia, lymphoma, multiple myeloma, myelodysplasia, and non-cancerous like hepatitis disease, mostly hemoglobin immunodeficiency disorders or affecting the present from the birth, that is stage progressive thalassemia, particularly thalassemia major. Procedure to treat the patient is first things that the bone marrow, I am taking only bone marrow, but the procedure is almost the same. Slightly there is a differences between organ to organs. So bone marrow transplant or replaced by the unhealthy blood forming immunity. Bone marrow harvested, Then from matching bone marrow donor is given to the recipient. Next slide. The main problem is graft versus host reactions. This is something the any organ of the tissue which is transplanted to the recipient, there is amino system most of the time that not accept that organ tissue of the cell. Then there is some kind of diseases which is come in existence that the rejection takes place. For that, immunosuppressive agent is given. So before transplantations, first is the blood groupings is must, then HLA typing. HLA typing, you know, that is human lymphocyte typing, mostly T and B cells, if they are matching, then the successful rate is more, otherwise the rejection chances are there. And what are the problem that occurs? Like next slide. These are the some complications, and in this 15% death is also take place due to the rejection. These are the adverse gastrotypes: tract, skin, hair follicles, lungs, blood vessels, liver. Even the hair is also get when we treat the patient of cancerous cases. First time there is almost wild, that is all the hair is get lost, but ultimately when it is stored again come. Next slide. These are the conditioning, it means preparing of the patient for the bone marrow transplantation. Then stem cell transfusions takes place. Then engraftment, then post-engraftment period. Next slide. Engraftment during this period, it takes from several weeks. Sometimes rejection is within this period takes place, and the signs are fever and graft versus host reaction, etc., fever, rashes, etc. Then this period, that is post-engraftment period, this is months. And gradual, we are giving the suppression, ultimately that suppression period is over and we give its own system try to adjust that cell within the body. So in this period, the most opportunitous infections in medical field, we say it is more opportunitous in this period that infecting and due to the infection, the death rate is high. Next. Next is the during this neutropenic, that patient has a severe pain and ultimately that is going out, that is get reduced. Next. This is already covered. Next. So I told you regarding conditioning phases, this physiotherapy or therapy, radiotherapy is given so that whatever the affected cells, they try to kill it. Next. Now, so after that, this is the due process in which when the person takes place, his umbilical cord line is taken and kept in a place whenever is required in his life. This can be again used for this purpose. That's right. So, thank you very much. If you ask the question, you can. Otherwise, you can send me because
If anybody is having any type of question, he can ask later. Thank you so much, sir, for sharing your kind thoughts. Now, I request all of the delegates and students to please have a tea and snacks.
William.
We will start the rest of the session after the tea break. Thank you.
Yun. Uy, yo, hava,
requested to assemble in the auditorium as we are going to start our new session. Delegates and students are requested to fill up the first seats. Please fill up the first seats. Come on. Now, we are going to start our next session from the Department of Renal Science and Dialysis Therapy Technology by Mr. Muntazir Rashid. Mr. Muntazir Rashid is currently working as an assistant professor at Bhai Gurdas Group of Institutions, Sangrur. He is a nationally awarded writer and artist. Mr. Muntazir Rashid is currently working as an assistant professor at Bhai Gurdas Group of Institutions, Sangrur. He is a nationally awarded writer and artist. He holds the credit for publishing 3 research papers and is a life member of the National Association of Nephrology Technologists. He has also been honored with prestigious IBR and APR awards for creating the smallest origami flower with a stem, an achievement that earned him recognition in top global news portals and print media. Mr. Muntazir has received numerous awards at both local and national levels. Notably, he was recognized as one of the top 100 authors by Fox News India. He also had the honor of representing India as a young leader at the Model United Nations held in Indonesia, Thailand and Istanbul. Beyond writing, Muntazir has made his mark in various art forms including mandala art, mural painting, sketching, origami, nail and thread art, calligraphy and many more. I welcome you, sir, on the stage and request you to share some thoughts. Hello.
Good morning. It's my privilege to be here today among such esteemed professionals and learners. I, Muntazir Rashid, working as an assistant professor by Gurdas Group of Institute, I invite you to take a moment, not just a healthcare professional, but as a human being. Imagine waking up every other day not to plan your dreams, but to plan a machine. A machine that keeps you alive, but also quietly steals away your time, your energy, and of course, your freedom. I'm honored to share insights on topic that often overlooked but deeply impactful. Mental health challenges in CKD patients undergoing mental illness hemodialysis. Why talk about mental health in dialysis? In our race to manage lab reports and survival rates, we often forget one thing, the soul of the patient. Imagine spending 12 to 15 hours a week hooked to a machine, feeling like life is slipping away through your fingers. How many patients cry themselves to sleep? How many smile when we walk in, but are breaking inside? Mental health is not optional, it is the core part of healing. CKD is not just a diagnosis, it is a journey of loss. First, they lose their energy, then their work, sometimes relationships, and eventually the ability to live independently. Maintenance hemodialysis keeps them alive, but often at the cost of their emotional freedom. It like being trapped in a cycle with no escape and no end. Depression is not just sadness, it is the absence of hope. And anxiety is not just worry, it is a constant fear of tomorrow. Imagine waking up every day unsure whether your body will cope up or if you will survive another day. These are not real experiences, these are the norms for many dialysis patients. They feel like a burden. Their bodies change, they lose confidence, and they feel invisible in society. The machine becomes life, but also chain. Many can no longer work, travel, or even enjoy a meal without restriction. Their world shrinks, and mental health begins to deteriorate. What do numbers say? Numbers don't lie, and these are heartbreaking. 1 in 3 patients on dialysis suffers from depression. Anxiety is just as highly shockingly. The suicide risk is twice that of the general population. These are not just statistics, these are the cries for help. Silent cries that we must no longer ignore. How can we measure here
thoughts. Now, we will be having a special talk from the Department of Operation Theatre and Anesthesia Technology by Mr. Suhail Anjum. Mr. Suhail Anjum is a highly experienced anesthesia technologist and tutor with over 7 years of experience in the field. He has worked in Srinagar. He is currently working as an assistant professor at Khalsa College Technical Campus, Jalandhar. Mr. Suhail is passionate about his work and is dedicated to providing the best possible care to the patients. He has published several research papers in various international journals and is a certified BLS and ALS provider. I on the stage and share some thoughts.
It's unique.
Good morning, estimated professors, respected delegates, and my teachers. It's my both privilege and honor to stand in front of you today at the Raidwara University to explore the topic that's not only the advancing modern medicine but also researching the patient's experience. That's innovation in regional anesthesia. Let's go to the background of the regional anesthesia. The general of regional anesthesia began in the early 20th century. Regional anesthesia is a technique used to induce analgesia or anesthesia in a specific region of the body by blocking the nerve conduction. It's essential component of the modern anesthetic practice, offering the numerous advantages over the general anesthesia, such as reduced systematic side effects, better pain control, and quick recovery time. Historically, regional anesthesia was performed using landmark basic techniques and blind approach, like heavily on the anatomy and palpitation. So it has some advantage over the general anesthesia like avoidance of airway manipulation, less systematic side effects, better post-operative pain relief, early ambulation and discharge, low incidence of deep vein thrombosis and respiratory complications. There are different methods to give the general anesthesia, regional anesthesia, like peripheral blocks, spinal anesthesia, epidural anesthesia, combined spinal and field and fan blocks. But it can be only given in two methods, that's regional anesthesia and the pan management. So, if we go for the evolution of regional anesthesia, it starts from the blind approach, then with the era comes the nerve stimulator, CT guided, and ultrasound guided. So, if we go for the blind approach, it relieves a lot of experience, anatomical marks. It relieves the injection, the anesthetic direct into the nerves. Okay, so it has some highly disadvantages like risk of nerve injury, increased chance of vascular puncture, and less broader success. That sometimes we say that spinal failure. Has anyone worked you in the hospital in OT? Has anyone worked in the OT? Did you see that some patients have we give the spinal anesthesia, but the spinal anesthesia is not accurate? This due to the spinal failure. This is some technique which we use in lateral or steam position. Sorry for the inconvenience, especially the videos are not played. So next is the nerve stimulator. It's a step forward. Nerve stimulator involves the identify the nerve location through the muscles fusion guiding the needle and placement. It requires the same amount of drug what we give in the blind approach. This is the nerve stimulator. You can see the picture of the nerve stimulator. It is not mainly used in the present area. Okay? Now it's called the CT guided regional anesthesia. The CT guided regional anesthesia is mainly used for the pain blockage. Okay? So now it comes the era of ultrasound guided regional anesthesia. What ultrasound guided regional anesthesia gives? It gives a real time imaging of the nerves, vessels, and surrounding tissues. It has more advantage than other things like improved the accuracy and safety, reduced drug volume requirement, visualization of the needle trip and drug spread, fewer complications like nerve injury or vascular injection. Because in ultrasound guided anesthesia, we can easily see the nerve bundles, see the path, see the vascular area. But it has some disadvantages. Like others, it needs two-hand coordination, it needs lots of experience. So, expanding in the novel ultrasound anesthesia, it has airway assessment, peripheral blocks, and spinal anesthesia. We give now this.
क्या आपको मस्ती क्या करानी है?
Sorry for the inconvenience. Let's start the session, sir.
So it comes the ultrasound guided airway assessment. Okay, ultrasound guided airway assessment helps us in our difficult intubation. Okay, because it provides the structures preoperatively. It is useful in identifying the difficult airway predictors, guides placement of endotracheal tubes and confirms the location. For example, the ultrasound in the airway assessment uses the anatomy of the hyoid bone, thyroid and cricoid cortex, tracheal rings and epigloids. It predicts us the difficult airway by the given structures. It also provides us a confirmation of endotracheal tubes, whether it is in place or not. For example, if we go for the difficult intubation, everyone knows it will be 2 or 3 Malpathy grading. Okay, for that purpose we use ultrasound guided airway assessment for the better placement of the endotracheal tube. So that is called the hybrid intubation. Yes. These are some novel no block techniques in the field of regional anesthesia. For example, if we are planning for the ultrasound guided anesthesia, So we can convert that block into the continuously catheter block. For example, femoral block, where we can put the catheter placement. After that, we will produce continuously infusion in which you can see that we have produced an infusion pump near the block region where we can give the post-operatively medications for the pain management. Now, this is the innovations in regional anesthesia, that's ultrasound guided thoracic segmental block. Okay, what is thoracic segmental block? This is the most recent advantage in the regional anesthesia and the development of the ultrasound guided thoracic segment block. These blocks provide the targeted anesthesia at subsegmental block, which is given in the 3, 9, T10 region. Targeted spinal blocks at thoracic level for segmental anesthesia has the benefits as compared to the general anesthesia blocks like better hemodynamic stability than lumbar spinal, ideal for the thoracic surgeries and upper abdominal procedures. It's used in both adults and pediatrics, but in pediatrics it needs sedation. In adults, ultrasound guided thoracic segment block are utilized for the post-operative pain management and subarachnoid block. A technique in thoracic and upper abdominal surgery that provides the effective anesthesia with the minimum specific opioid use. Same is in the pediatric patients, but in pediatric patients, it needs sedation. This is the ultrasound guided thoracic segmental spinal anesthesia success rate. About 90% success rate has been in this field. Thank you. Any questions?
Who has to ask the question? Please raise your hand and come out with IL. IL means this way. Sir, please.
There is a need of surgery.
Yes, sir.
Need of, you are saying, because you are.
Sorry, sir, I am not understanding your question.
Is the problem with my voice?
No, sir. Your wife is broken.
You are saying if you are giving the anesthesia to the pediatric patient, there is a need of sedation.
Sedation, sir.
Yeah, why?
Basically, sir, the thoracic segmental spinal anesthesia is given in the region of T3, T4. If the pediatric patient has some issues in their lungs, for example, they have only one lung, or they have any comorbidities. So for that purpose, if they have any type of surgery which is going on, like a laparoscopic appendectomy, laparoscopic cholecystectomy, which cannot be done under the general anesthesia. So for that risk complications, patients are being sedated for some period of time, so that we can give the thoracic segmental spinal anesthesia to the pediatric patients, as pediatric patients are not cooperative at that time. Sorry, sir, repeat.
What is iron drug delivery?
Sir is asking about what is the role of iontophoretic drug delivery system in regional anesthesia. Iontophoretic drug delivery system is a system where the drug passes across this barrier of the skin through cathode and anode electrodes. Right? Anybody else who wants to ask a question?
What is the role of USG in assessment of the difficult airway?
Sorry, I already told you that in the session. Still, I will show you the role of ultrasound in assessment in difficulty airway. Okay, ultrasound is an emergency as a non-invasive best tool for the placement of difficult intubation. For example, it gives us the proper anatomical structures. We call that sonoanatomy. Okay, it gives us the structures of hyoid bone, thyroid bone, tracheate and tracheate rings, okay, by which we can show where the placement of the endotracheal tube goes. As you all know, in difficult intubation, there is a less chance of intubation purpose. For that, we can go for the ultrasound guided difficult area management, which gives us the proper sonoanatomy of the structures and proper placement of the endotracheal tubes. This technique is now converted into the new techniques. Okay?
Okay, thank you, sir. So, why drug volume is higher in blood than in USG?
Very good question. So, in a blind approach, the doctors didn't see the proper anatomy and the proper nerves of the given structures. For that purpose, we give the larger amount of drug as compared to the ultrasound guided anesthesia. In ultrasound guided anesthesia, we can clearly see the nerve branches, nerve bundles. But in blind approach, we never knows where the needle goes. In ultrasound guided anesthesia, we can see the nerve path, but in blind approach, we never knows where it goes. I have added the video.
बोलो बोलो आप कंटिन्यू करो.
I have added the video in the presentation, but for that the video doesn't open here. So you can clearly see that blind approach we use the techniques of landmarks and analytical watch. We use analytical marking in the blind approach while we can use the drugs. Okay? Any other?
Thank you so much, sir. It was really an insightful interacting session.
वहाँ किधर बैठ जाते मैं उसको काम पे करनी है कहीं करना तो चाहती हूँ कौन उठे ऐसा अपने अंदर दूसरा आदमी बाहर करना क्या क्या तू उसी घर में चली बेटा
What's that, sir? My publisher. मुझे बताना जल्दी स्टार्ट करेंगे माइक नहीं चल रहा है This was all about the today's panel session of the conference. Thank you so much, everyone. Now I request Dr. Aprajita ma'am on the stage and start the researchers forum.
Good morning, distinguished delegates, respected faculty, researchers, and dear participants. I trust the hot tea has fueled both your energy and curiosity. Let's now dive into the heartbeat of this conference, the Researchers Forum, where ideas speak revolutions and science becomes a song. A standing ovation, please, for our luminous judges, Dr. Neena Mehta and Dr. Pankaj Kaul. Your wisdom lights our path and your presence is our pride. Let's applaud their tireless spirit and time they have spared. Ladies and gentlemen, this is where the future whispers. Through your research, each presentation is a brush stroke on the canvas of biomedical innovation. I urge you all to listen with rapt attention and hearts wide open. Let's welcome our first presenter, Shamaita Basu. Shamaita Basu.
A very good afternoon to one and all present here. A very good afternoon to one and all present here. I am Dr. Shamaita Basu from Usha Martin University, Ranchi. I am working as Assistant Professor in the Department of Biomedical Sciences. So today my topic is isolation and identification of MDR uropathogenic Escherichia coli samples from UTI patients. So before moving on with my topic, I would just like to say that this is a very brief and basic study, and the main focus or the main utility is to spread the awareness about the rampant occurrence of multiple drug resistant nowadays in diseases as common as UTI, and therefore how we can modify or we can think of alternatives for the patients for better patient care. So, starting with the presentation. So as we all know that UTI is mostly caused by bacteria and it infects our urinary tract, and it's more common in women than in men because of several factors which I will be talking in the upcoming slides. And among the bacteria that generally cause UTI, one of the most common bacteria is E. coli. And among E. coli, uropathogenic E. coli is seen to cause most of the UTI cases. And in this UPEC, that is uropathogenic E. coli, the cases or the occurrences of multiple drug resistance is mostly seen. And one of the main reasons for this multiple drug resistance is gene transfer, particularly the resistant plasmids, which are plasmids are a very unique feature of bacteria which actually contribute to this antibiotic resistance. So next, moving on to the different types of UTI depending on which tract they are actually infecting. So if it's the upper tract infection, then it's known as pyelonephritis. Then we have the lower tract infection, that is cystitis, and also we have urethritis. Now talking about which I mentioned earlier also, that why is UTI more common in women than in men? That is because several factors are there. So the first or the most important factor is that in women we have a shorter urethra, as a result of which the normal bacteria which already resides in our vagina and anus they can easily travel from those regions and become pathogenic and invade our urinary tract. And then another factor is sexual activity, which is mostly seen in women having multiple sexual partners. Then we also have birth control, some specific methods like use of pharmaceutical agents and cervical caps is associated with more occurrence of UTI. And also another factor is menopause, because in postmenopausal women, the levels of estrogen decreases, as a result of which the normal vaginal flora is gone and it's associated with more occurrences of UTI. Talking about the pathogenesis, since time is limited, I will just give an overview. So the bacteria, they mainly affect the urinary bladder. So they colonize in the bladder and they aim to form a biofilm so that they can easily resist the antibiotics. And in this method of colonizing the bladder, they mostly follow their a particular pathway called the chaperone-usher pathway, which is mostly which helps them to secrete and assemble the adhesins or the pili or the fimbriae, so that they can get attached to the bladder wall. And also they produce siderophores, which are iron chelating agents, because our bladder is deficient of iron, and iron is a very important nutrient that bacteria require for multiplication. Talking about the causative agents of UTI, as I already mentioned, most common is E. coli, followed by Pseudomonas, Klebsiella, and also Proteus and Staphylococcus species. And when we focus on neuropathogenic E. coli, there are several virulence factors that they have as far as causing UTI is concerned. So they have hemolysins, alpha and beta hemolysins, which break down the cells of the bladder wall, and they also have some important factors which are responsible for their causing of UTI. Next, moving on to the objectives. So firstly, we collected urine samples from patients with proper ethical considerations and consent. Then we moved on to identifying E. coli samples among those samples. And lastly, what we did was we went for antibiotic susceptibility testing to see the multiple drug resistance pattern. So as we can see in this figure, growth was observed in about 20 samples from among 25 samples that were collected in total. Then we moved on to performing the routine biochemical tests like gram staining and other in-vitro tests, which showed that our samples contained E. coli. So from among, this is the summarized version of the biochemical test. So from among 20 samples, 15 samples were shown to have E. coli. And then we moved on to the most important part, that is performing antibiotic susceptibility testing by PB board disc diffusion method. And as you can see in this figure, in most of the bacteria, we can see that if we are giving around 6 antibiotic discs in a culture plate, then among the 6 antibiotics, only 2 antibiotics are able to work against the bacteria. So they are mostly resistant to most of the antibiotics. And then this is the chart where we can see we used 6 different classes of antibiotics. As you can see, we used amikacin, nitrofurantoin, ciprofloxacin, ampicillin, and also cephalosporins. And we saw that most of our samples, like from among 15 samples, 10 samples showed resistance to at least 3 or more drugs. So from there we can draw a conclusion that majority of the samples were resistant to the 6 different classes of antibiotics that we used. So among 15 samples, 10 samples could be considered to be multiple drug resistant. So this is the summary of the total result. So in conclusion, we can say that multiple drug resistance is increasingly a concerning factor as far as treatment of UTI is concerned. And so what we can do is, for better patient care, we can go for plasmid profiling to see the genes or the accurate reasons for this multiple drug resistance. And for better patient care, we can do prior screening of the patient samples. like prior antibody sensitivity testing to see that whether the antibiotics, which antibiotics are not being able to work, and accordingly we can prescribe antibiotics to the patients. Thank you.
Dr. Vasu, you have used penicillin as a drug sensitivity test.
Yes, sir.
Okay. So why you are not using New World Medicine amoxicillin?
Amoxicillin.
Yeah.
So we have used ampicillin and amikacin. We have used 6 different classes of antibiotics, among which we have used penicillin, we have used cephalosporin, we have used ciprofloxacin, and we have used nitrofurantoin also.
My question is regarding penicillin, especially.
Yeah.
Why you are not using new medicine? That's analog of penicillin.
Sir, actually over here we have tried to show the traditional or the most common antibiotics, like how these bacteria are actually not working against this traditional or conventional antibiotics. So we need to move on to the newer versions or modifications of these antibiotics.
Anyone from the audience?
Ma'am, as you have said, like MDR. So MDR is mostly found in for like pregnant woman is very high and normal woman is very less. So whenever we are going for the antibiotic sensitivity test for MDR, like in pregnant woman, for those patients like nitrofurantoin and clindamycin, that is like sensitive, not less sensitive. But for normal patient, normal woman we are going for like clindamycin, sulfamethoxazole, like it's very less. So why this kind of things are?
Sir, I think this is a trend which is seen in pregnant women mostly. So I think some factors may be associated with pregnancy, which as a result of which they are being more sensitive.
No, ma'am, actually, in the scenario of pregnancy, where immunological path will be different. So,
Yes.
in that scenario, when you are using the clindamycin and sulfamethoxazole, so that time it resists the patient. But same drug, same dose, and like same body weight patient, when you use it for the normal patient, and it is effectively used like effective. So, why this kind of association?
Like you were saying, because of immunological response, it's happening.
Like sometimes like, there will be some like hemodilution will be there in the pregnancy. But that time will be drug concentration will be increased. So to maintain that concentration of the drug, like loading dose and maintaining dose. So as we maintain the normal patient and pregnant patient, but apart of that also one is perception will be there regarding this test, sensitivity test.
Like between pregnancy and non-pregnant women. Sir, I think that will be for that study we need to focus on pregnant women also. But here the samples were not taken keeping in consideration pregnant and non-pregnant women. So I think that will be a different aspect of this study.
So your study is only against the not non-pregnant women.
No, sir. No, sir.
Ma'am, I want to ask you something.
Yes, ma'am.
That for the common people to identify the urine infection, we definitely go for the urine culture. After the urine test,
Yes.
then we will go for the culture test. When we should need the ASC? I mean, this is not a very common test for the people.
Yeah, ma'am, actually that is what I'm like trying to show over here, because in many samples we are seeing that most of the commonly used antibiotics are actually not working. So what we can do is, as future prospect for better patient care, we can do patient screening initially before prescribing them the antibiotics. We can actually do the AST and see that what are the antibiotics which are not working, so that we can be aware that we should not prescribe these antibiotics and we can go for some alternative antibiotics which will be working in those patients.
Okay, so ma'am, after culture of the urine test,
Yes.
then we should go for the AST, or first we have to go for the AST test, then
Ma'am, I think after culturing only the AST will be better. Yes, ma'am.
Thank you, ma'am.
Thank you.
Ma'am, I have to add one thing for your future planning. Wherever you have got some moderately sensitive or you can say moderately resistant organism,
Yes.
you try cranberry to those patients.
Okay, sir.
Cranberry does not allow the colonization of the organism in the urinary tract.
Yes, sir.
Just try that.
Cranberry juice, right?
Yeah.
Yes, sir.
No, it's not juice also. You can get it
In the form of tablets also, yes.
tablet also, capsules also, and raw also you can
Yes,
get.
sir, yes, sir, yes.
And find especially those who are vulnerable, like you told me, menopause cases and
Yes,
that,
sir. Yes.
like
And also in patients who are having low bacterial load.
it is safe also because giving antibiotics can create some other problem also.
Yes,
You
sir.
have
Side effects.
gastritis and all that.
Yes,
So
sir.
to avoid that, it is better to have cranberry sufficient of
Yes, sir.
to drink.
Yes, sir.
That will take care of that. And just see what profile comes after that.
Yes, sir.
And in next conference, which is going to be held in Guwahati at ICMLS, you present that data there.
Yes, sir. Sure, I will try.
You to speak there in Guwahati.
Okay,
Probably in November, there is a conference going on.
Yes, sir, I know.
It is for the information of all the audience sitting in the auditorium that there is a conference going to be held in Guwahati in probably November. So of ICMLS, Indian Confederation of Medical Health Science.
Yes,
So try everybody, prepare yourself for that and attend that in numbers. Thank you.
Yes, sure. Thank you, sir.
From the
Next.
comments, please ask any question. Raise your hand. Hello.
Yes, sir.
Ma'am, good afternoon. My name is Dheeraj.
Yeah, good afternoon, sir.
Ma'am, I want to ask a question that as far as economic is concerned, they will consider at the commencers, right? And once the CFU is increased on a higher range, they become the better areas, right? So first I want to confirm it from your end that you have shared in the profile that the biofuels are being produced. So do we have that relevant any reference that economies are producing the biofuels?
Any reference as in as far as UTI infection is caused?
Yes, as far as UTI is concerned.
Yes, sir. I have reference, but right now I can't produce it because I have not included it in the PPT. But it has been found that few biofilms are producing biofilms. Few E. coli are producing biofilms.
The purpose of asking this thing to you was quite simple. That if the biofilms are being produced, so at that stage of infection, the chances of using the higher that antibacterials increase.
Yes,
so
sir.
it is a bit obviously that cephalosporins and your if you see
Ampicillin.
and ampicillins, they will be definitely resistant.
Exactly.
And compare E. coli with Pseudomonas aeruginosa, where the are being produced on the higher side, and these gram-negative rods they are very much notorious, as you know. And even the bacteria also they have changed their behavior as well.
Yes.
So in that case, which drug should be given to the patient, specifically into PIs, specifically UTIs? Drug of choice I'm talking about.
Yes, sir. So we can try with sulfamethoxazoles and trimethoprim if they are not working.
Sulfamethoxazole.
Yes, sir.
And
Trimethoprim. Yes.
That's
Thank
it.
you, sir.
That's what I was saying.
Thank you, sir.
Next one, please.
Next we have Miss Inderjeet Kaur.
Good afternoon, everyone. Myself, Inderjeet Kaur. I am Assistant Professor, Department of Medical Microbiology, University School of Allied Health Sciences. Today my topic of oral presentation is seroprevalence of typhoid fever in urban population of Panipat, Haryana. Introduction. Typhoid fever is a life-threatening foodborne illness caused by Salmonella typhi, a gram-negative bacilli. It is characterized by the fever, abdominal pain, and other systemic symptoms like diarrhea and fever and then your weight loss, often leading to significant morbidity and mortality if left untreated. Geographically, South Central and Southeast Asia counted for high incidence more than 100 per 1 lakh cases per year as compared to Asia, Africa, Latin America, the Caribbean, Oceania, that is 10 to 100 per 1 lakh cases per year. Conversely, Europe, North America and other developed regions exhibited low incidence rate, less than 10 per 1 lakh cases per year. According to one study, India recorded approximately 10 million cases of typhoid fever in 2021, making it the highest burden of typhoid worldwide. Typhoid fever risk was higher in urban location, 576 to 1173 cases as compared to 35 cases per 1 lakh child per year in the rural sites. Salmonella typhi has rapidly gained resistance to the antibiotic like ampicillin, chlorphenicol, clotrimazole, in addition to the previously efficacious drugs like ciprofloxacin. Salmonella isolate shows fluoroquinone resistance in a study conducted in Haryana. In another study, Salmonella shows the presence of resistant gene for fluoroquinone and azithromycin, indicating the presence of antimicrobial resistance. The present study, my study, aimed to assess the prevalence of typhoid fever in the urban population of Panipat, Haryana, and to ascertain the dominance of type of antigen. Materials and method. Study design. This study was conducted at the Kashyap Diagnostic Center situated in Panipat, Haryana. The study duration, it is a 2-year study, data from January 2023 to December 2024. A sample size, a total of 1089 blood samples were collected from the patients suspected of the typhoid fever around different locations of the Panipat city. The inclusion criteria, firstly the samples were taken with the suspected cases of Salmonella infection, and secondly the patients were divided with the age group between the 3 years to 65 years. Exclusion criteria, samples were from the rural area of the Panipat city were excluded from the study, and the patient with age less than 3 years and more than 65 years are excluded from the study. Statistical analysis, basic statistical parameters were calculated using MS Excel for the determination of prevalence rate. The data was subjected to t-test to ascertain the dominance of the type of antigen. This is the result, distribution of the population based on the age. Based on the age sample, based on the age, the samples were divided into 2 groups, children and adults. Out of 1089 samples, 979 samples were of the children, that make about the 90% of the total population, and of the 1089 samples, 110 samples were of the adult, that make about the 10% of the total population of the study. This is the prevalence rate of typhoid fever in the Panipat city. In the year 2023, the total population was 570 and the positive cases were 253, that makes the prevalence rate 44.38%. In the year 2024, total population taken were 519 and the positive rate was 252, that make the prevalence rate 48.55%. Overall, of both the years, of 1089 patients, the positive samples was 505, that make about the 46.37% prevalence rate. Of both the years, 2023 shows lesser prevalence rate as compared to the 2024, and in the year 2024, the prevalence rate of typhoid increased up to the 4%. Now the result on the basis of dominance of type of antigen. Out of 1089 samples, 505 were positive. Sorry, out of 505 positive samples, 32% cases shows somatic antigen and 20% cases shows H antigen, flagellar antigen, and both H and O and H antigen makes about 48%. In the year 23, this is the dominance of type of antigen in 2023. In the year 2023, the total positive cases were 253, and out of these 253 cases, O antigen marks about 29%, H antigen, flagellar antigen marks about 21%, and both O and H antigen marks about 50%. The rate of positive cases were more in the year February and October. Dominance of type of antigen in the year 2024. Out of 252 positive cases, O antigen shows 35%, H antigen shows 21%, and both O and H antigen makes about 44%. And in the year 24, in the month of October, more positive cases were seen. Now the salient findings. The study suggests the average prevalence rate of typhoid fever in the Panipat city was around 46%. Children were more susceptible to the salmonella infection as compared to the adult. The prevalence of somatic antigen was more than the flagellar antigen, indicating more recent infection in the area. The prevalence of both antigen positive was higher than that of both O and H antigen alone, indicating recent as well as past infection. H antigen positivity indicate about immunization. The highest positivity was reported in the month of October, that is after monsoon. Conclusion. The study reveals that O antigen is more prevalent in Panipat city with comparatively high incidence rate. The study also suggests more testing and quantitative assessment of the bacterial load in the population along with the antibiotic susceptibility status of bacterial isolates so that the better prevention and treatment strategies can be planned. These are the references. Now acknowledgement. First of all, I would like to thank Riyad Bahra University, Mohali, for giving me the opportunity to present my work. I would like to sincerely thank Professor Dr. Pankaj Kaul, Dean USCHS, RBU, for his guidance and support. I would also like to convey my thanks to Dr. Arindam Adhikari, Assistant Professor, Department of Microbiology, for helping me during this work. I convey my deepest gratitude to Dr. Richa Thakur for her support and help during this work. Thank you.
Ma'am, you have shown the data for positive and negative serum.
Yes.
What false positive data you have also mentioned?
Sorry, sir?
False positive in the case of typhoid, we know that it's normal complication. And false positive, yes. And what is the criteria of false positive?
So false positive cases mostly seen in the person who are being immunized in the previously. They shows false positive test, sir.
And after the treatment of typhoid, completing after the dose of typhoid, how and at which range you are considering it like false positive?
So actually, this is the collaborative study that I have done with the Dr. Kashyap, MD pathologist. So I don't have any idea. The patient did not report it after the treatment, sir.
Ma'am, I want to ask you one question. That you have taken the sample size of 1089, right? How do you choose this sample size? Like the random
Ma'am, this is random sampling. The study was conducted at Kashyap Diagnostic Center, a pathologist lab at the Panipat. Whatever sample that are coming to the lab, we have just collected that sample for 2 years.
Okay, with the symptoms, ma'am, like
suspected case of typhoid.
Suspected
Yeah,
case of typhoid. Thank you, ma'am.
Ma'am, you think that there is a contamination of water because of that it is happening?
So actually Panipat is basically an industrial area.
What is the source of that water? Just like in Chandigarh, there is a source of water is Bhakra Dam and all that. What is the source of water supply in Panipat?
So source of water supply.
Is it tube wells or what?
It's a tube well basically. It's groundwater.
Groundwater.
Sir. But it is more as industries are more in the urban area of the Panipat, the water is more contaminated there, sir.
Okay.
Hello. Good afternoon.
Hello, sir.
Ma'am, this question knowledge only. This is not a question on the slide itself. But as far as your data is concerned, the data taken uh, from the children below the age of 3
Yes.
and the adults above the age of 65, right? Do you think that these kind of patients and people, they are already immunocompromised? And we are conducting the study not on the healthy people who can get, you see, wherein the chances of taking antibiotics and other medication is very much less. But in case of children and in case of the adults, it becomes high because their immune system is already weak. So the bacteria like E. coli, Salmonella, and that Neisseria gonorrhea, such kind of bacteria, they are targeting their patient below 3 and above 65. So my question is that why we are not conducting these kind of studies in the healthy patient aged from 14 and below 50.
So actually, I told this earlier. This is a collaborative study with the Kashyap Diagnostic Center. So whatever sample that comes into the lab, we pick the samples randomly, sir. So I kept your suggestion. So that was not planned. It was just a study. Random samples were taken. That is why this age group is chosen, sir.
And ma'am, as far as the area is being concerned, if I speak of the area like Panipat or Noida, Muzaffarnagar, northern region of UP, this part is industrial area basically,
Right, sir.
and the chances of contamination is very much high.
Very much
We
high.
cannot comment that this is the particular bacteria who is going to work there and causing the infections, right? So can we compare this data with the eastern part of Punjab, like in Amritsar, Jalandhar, Kapurthala, wherein the water level and the quality of that water is same as that we are having in the Delhi part. So can we compare the data over there as well? We can take that data for that also.
So we will try. We can try that also.
See, because if you check the data for past 5 years, you will see that the typhoid fever has picked up specifically in these areas, like in that Amritsar belt and in your Panipat, Jhajjar, Rewari, Rohtak and Noida. The prevalence of typhoid is very much high there and there as well.
Right, sir.
And that too in a specific season, I must say.
It's after the monsoon, sir. The data is
Exactly, close to the monsoon itself.
Yes, sir.
When the rain is high and the sewage is high. So I'm coming back to my question again, that can we take this data in reference with the data to Amritsar and then?
Sir, if the area, you can say if both the areas are having lot of industries, then we can also compare the data, sir.
Top difference, I must say.
Sorry?
Difference. There will be a small difference, I must say.
So I'm not getting you properly.
There will be a small difference in the data.
Okay.
That gets analyzed.
Maybe, sir.
Thank you.
Okay, sir. Thank you.
Next is Sakshi Bansal.
Hello. Good morning, sir. Good morning, sir and ma'am. I am Sakshi Bansal from Chikai University. I am presenting my comparative review analysis, knowledge and attitude regarding health science and non-health science university. Sorry, I am presenting a review analysis on knowledge and attitude regarding antibiotic resistance and use of non-health science and health science university students. They are the keywords: antimicrobial resistance, antibiotic resistance, and the contents. Introduction. First, लेट्स सी नाउ व्हाट इज द एंटीबायोटिक। एंटीबायोटिक एक ऐसी मेडिसिन होती है जो हम यूज करते हैं बैक्टीरिया को ट्रीट करने के लिए, बैक्टीरिया इन्फेक्शन को ट्रीट करने के लिए। बट एंटीबायोटिक रेसिस्टेंस मीन्स when the bacteria become resistant to antibiotic drugs, antimicrobial represent एक major global health problem, एक major global health problem है। जी इंडिया में अराउंड 3 lakhs डेथ हुई है ड्यू टू द AMR इन 2019 में, जब उसे एस्टिमेशन किया गया कि AMR कितना डेथ है अराउंड। अगर इसी तरीके से कंटिन्यू रहा ये प्रॉब्लम, 2015 में एस्टिमेट किया कि 2 मिलियन डेथ हो सकती है हर साल। तो अगर इफ दे हैज नॉट टेकन एनी एक्शन दिस प्रॉब्लम, द मेजर फैक्टर जो प्रॉब्लम इसे इम्प्रूव, द मेजर फैक्टर जो इसे वो कर रहे हैं, रेसिस्टेंस क्रिएट कर रहे हैं, बस खुद से मेडिसिन ले लेना, इम्प्रॉपर खुद से मेडिसिन ले लेना, इनकरेक्ट डोजेस, सही स्क्रिप्टिंग कर लेना, अपने डोज को कंप्लीट ना करना, उसको गलत मेडिसिन ले लेना, जो कि एंटीबायोटिक वो लेना जो नॉन इन्फेक्शंस बैक्टीरिया कॉज कर रहे हैं, जो कि मेजर इसलिए मैंने ये था कि द इम्पैक्ट ऑफ AMR के बारे में बताया था कि ह्यूमंस में क्या इम्पैक्ट करते हैं। जबकि हम गलत तरीके से एंटीबायोटिक का यूज़ करें, जैसे कि सेल्फ मेडिकेशन लेना, गलत डोजेस लेना, जिस वजह से हमारे जो एंटीबायोटिक होते हैं मोर्टेलिटी, जैसे मैंने आपको बताया कि एंटीबायोटिक बैक्टीरिया बिकम रेसिस्टेंस हो रही है, जो बैक्टीरिया किल नहीं हो पा रहे, पहले क्या करते थे किल हो जाते थे, अब गलत तरीके से लेने की वजह से बैक्टीरिया क्या हो रहा है, रेसिस्टेंस हो रहा है, और रेसिस्टेंस होने की वजह से मोर्टेलिटी रेट जो है वो इंक्रीज हो रही है। लॉन्गर हॉस्पिटल, लोगों को जो पेशेंट्स हैं उनको लॉन्गर हॉस्पिटल स्टे रहना पड़ रहा है, और मेडिकल एक्सपेंसेस जो है वो ज़्यादा से ज़्यादा हो रही है। तो कि अगर ज़्यादा से ज़्यादा मेडिसिन ले रहे हैं तो जो हमारे नॉर्मल फ्लोरा जो बैक्टीरिया होते हैं वो डाई हो रहे या बैलेंस उनका बिगड़ जाता है, जिस वजह से क्या हो रहा है कि हमारे साइड इफेक्ट्स हमारे इंक्रीज हो रहे हैं। एंड थर्ड, इंडिया ने नेशनल एक्शन प्लान जो 2017 में स्टार्ट किया था, जिसमें 6 स्ट्रैटेजी थी। जो फर्स्ट स्ट्रैटेजी ये थी कि अवेयरनेस करवाना थ्रू द इफेक्टिव कम्युनिकेशन एजुकेशन। एजुकेशन एक ऐसा गैजेट होता है जो किसी भी इंसान का प्री एग्जिस्टिंग बिहेवियर को चेंज कर सकते हैं। थोड़ा उसके बारे में उसको समझा के जो उसका ओपिनियन होता है पहले का उसको हम उसको चेंज कर सकते हैं। बस जो नॉन हेल्थ साइंस स्टूडेंट्स हैं, हेल्थ साइंस स्टूडेंट्स को उनको एक हेल्थ साइंस स्टूडेंट एक एंटीबायोटिक प्रिस्क्राइबर है, फ्यूचर हेल्थ प्रिस्क्राइबर होते हैं, जिनको हम उनको एक कॉमन ट्रेनिंग दी जाती है कि एंटीबायोटिक क्या है, उनका एंटीबायोटिक रेसिस्टेंस क्या है। बट जो नॉन हेल्थ साइंस स्टूडेंट्स हैं, जो नॉन हेल्थ साइंस स्टूडेंट है वो फ्यूचर एंटीबायोटिक प्रिस्क्राइबर है, बट दे रिमेन एंटीबायोटिक, उनको प्रॉपर ट्रेनिंग नहीं दी जाती। देन मेरा जो एम ऑफ द स्टडी का जो ये है कंपैरेटिव एनालिसिस का, वो ये है टू असेस एंड कंपेयर द नॉलेज एंड एटीट्यूड रिगार्डिंग एंटीबायोटिक रेजिस्टेंस, हेल्थ साइंस एंड नॉन हेल्थ साइंस यूनिवर्सिटी स्टूडेंट्स। इस स्टडी के अंदर मैंने 4 स्टडी इंक्लूड की है, जिसमें हेल्थ साइंस और नॉन हेल्थ साइंस को इन्वॉल्व किया हुआ है। ये क्वेश्चन बेस्ड स्टडी है और इसमें पार्टिसिपेंट्स को रैंडमली ही सिलेक्ट किया है। जिस ग्राफ में ये जो ग्राफ है, फर्स्ट जो है फिगर नंबर 2 एंड फिगर नंबर 2 रिप्रेजेंट कर रहा है नॉलेज जो हेल्थ साइंस एंड नॉन हेल्थ साइंस स्टूडेंट्स के लिए, एंड फिगर नंबर 3 जो रिप्रेजेंट कर रही है एटीट्यूड रिगार्डिंग एंटीबायोटिक यूज एंड रेसिस्टेंस को। द फर्स्ट ग्राफ जो है वो जो क्वेश्चन जो उनसे पूछे गए थे उनको ये रिस्पॉन्स को बताता है कि कितना उनको अवेयरनेस है, जिसमें कि हेल्थ साइंस स्टूडेंट्स को उसकी ज़्यादा नॉलेज एज कंपेयर टू नॉन हेल्थ साइंस स्टूडेंट्स को। सेम एटीट्यूड, बट तांजानिया में डिफरेंट है, बट तांजानिया में नॉन हेल्थ साइंस स्टूडेंट्स को भी उनको एंटीबायोटिक के बारे में उनको समझाया जाता है कि एंटीबायोटिक क्या है। मेरा ऐसे अगर मेरा रिव्यू तो ये था कि हमने जब रिव्यू देखा कि जो नॉन हेल्थ साइंस स्टूडेंट्स हैं उनको जो उनको नॉलेज उनको लैक ऑफ लोअर नॉलेज है, लैक ऑफ एप्रोप्रिएट एटीट्यूड है regarding antibiotic use and resistance compared to non-health science students. जो non-health science students हैं उनको बहुत सारे मिसकॉन्सेप्ट है लाइक कि बैक्टीरियल इन्फेक्शन जो कॉमन कोल्ड इन्फेक्शन कॉमन कोल्ड हो गया, कॉफ हो गया, उसके लिए हम एंटीबायोटिक ट्रीटमेंट यूज़ करते हैं। पर कंपेयर करते हैं कि जो नॉन हेल्थ साइंस स्टूडेंट्स हैं उनको ज़्यादा नॉलेज है कि नहीं कि ये जो बैक्टीरियल इन्फेक्शन होते हैं हम उनके लिए एंटीबायोटिक ट्रीटमेंट नहीं यूज़ करेंगे, उनके लिए वायरल इन्फेक्शन ट्रीटमेंट यूज़ करेंगे। जब उनसे ये क्वेश्चन पूछा गया। सेकेंड, जो हेल्थ साइंस स्टडी जो थी वो दूसरी स्टडियों से कंपैरिजन किया जो कि अलग अलग स्टडी में हुई थी, जैसे नेसेरिया हो गया, जॉर्डन हो गया, अलग अलग स्टडी में भी यही बताया कि जो नॉन हेल्थ साइंस स्टूडेंट है उनको अभी भी इस चीज़ के बारे में अवेयर नहीं है कि एंटीबायोटिक एक स्ट्रीमिंग करना डोज को ये इंक्रीज कर रहा एंटीबायोटिक रेसिस्टेंस को। अगर हम इस चीज़ के बारे में उनको फॉर्मल ट्रेनिंग दी जाए एंटीबायोटिक के बारे में तो इस प्रॉब्लम को हम सॉल्व कर सकते हैं। द पॉसिबल सोल्यूशन यही था कि कैसे हम एजुकेशन के थ्रू हम उसको अवेयरनेस दे सकते हैं। द कंक्लूजन यही है कि उनका दोनों टारगेट को नॉन हेल्थ साइंस को फोकस करो, बाकी सारी पब्लिक जो हेल्थ साइंस हो और नॉन हेल्थ साइंस हो कि जिनको अवेयरनेस मिले इस चीज़ के बारे में, जो कि वो दूसरों को भी अवेयरनेस करवाए एंटीबायोटिक रेसिस्टेंस के बारे में, जिसको वो सीरियस माने और वो उसको फॉलो करे और उसको सीरियस लेके वो अपने डोज को कंप्लीट करे, अपने डॉक्टर से एडवाइस ले, ना कि फार्मेसिस्ट से जाके एंटीबायोटिक को प्रेफर करे। और उनका जो यूनिवर्सिटी लेवल पे उनको इंटरेक्टिव सेशन दे इस चीज़ के बारे में, जिससे वो उसको वो फॉलो करें और उसको अवेयरनेस करें। हम इस प्रॉब्लम को हम टैकल कर सकते हैं।
मैडम आपने सैम्पलिंग मेथड जो लिया है।
हाँ जी सर।
सैम्पलिंग में व्हाट इज द मेन प्रिंसिपल ऑफ सैम्पलिंग?
सर सैम्पलिंग मेथड मीन्स कि हमको सैम्पलिंग मेथड में जो नॉन मोबिलिटी सैंपल मैंने यूज़ किया है, जिसमें क्या होता है कि हम रैंडमली पार्टिसिपेंट को सिलेक्ट कर सकते हैं।
आपने नंबर को परसेंट नहीं रखा, तो एक वेरिएबल को आपको परसेंट रखना होगा। एरिया एक होता है, एरिया एक एरिया से हम सैंपलिंग ले रहे हैं, नंबर ऑफ पीपल, हाउ मेनी नंबर ऑफ पीपल अट्रैक्टेड या यू हैव एडेड, बट देयर इज डिफरेंस इन नंबर कंट्री वाइज, सो हाउ विल कंक्लूड?
सर एक्चुअली मैंने सिर्फ जो हेल्थ साइंस स्टूडेंट्स के थे उनका टोटल देखा कि कितने लोगों ने पार्टिसिपेंट्स को टोटल किया है, फिर जाकर मैंने उसको टोटल करके और जो नॉन हेल्थ साइंस को टोटल करा अलग अलग करके फिर उसको निकाला।
डू यू थिंक the data is authentic?
सर क्वेश्चन,
Do you think this data that sampling you have to get it authenticate your data?
Sir, it's not accurate. It's an awareness कि antibiotics not only health science, it's also useful for all of us, not only health science. It is awareness.
It is a very wonderful attempt that you are standing on the floor of this auditorium. आप सब बच्चों के लिए बेटे ये रिक्वेस्ट है मेरी that this child has worked very hard and ये जो फुमड़ी होती है, but thank you very much. All this fumbling she is doing better than what I did in my first representation. My legs were trembling and my tongue was stuck. But she still struggled for it. I arranged water for her also, but she did very well. Very nice. Thank you very much for that. I just want to know that the data which you have collected, how could you reach to these countries? Number one. Number two, for all countries you have written in capitals, but one country you have written in lowercase. So this has to be taken very much care when you make the slides. You should be very perfect in writing. If all are caps, everything should be in caps. Okay? In future, you keep it in mind. So, my question is that how could you reach these 4 countries? Why didn't you include India?
सर मैं भी देखो कौन सी थी जो मैंने एक्चुअली मैंने सबसे पहले अलग अलग गूगल स्कॉलर पबमेड पे सर्च किया कि इंडिया की स्टडी हो इस चीज़ के ऊपर हेल्थ साइंस के ऊपर और नॉन हेल्थ साइंस को लिया हो पर इंडिया ने आंसर नॉन हेल्थ साइंस को ही नहीं दिया जितने भी मैंने आर्टिकल लिखे हैं यूए में लिखे हैं जॉर्डन इजराइल सारे अलग अलग स्टार्ट किया नॉन हेल्थ साइंस को लेना बट इंडिया ऐसा कंट्री जिसने अभी तक हेल्थ साइंस को ही वो इंक्लूड करा एंटीबायोटिक का नॉन हेल्थ साइंस को अभी तक इंक्लूड नहीं किया.
But what was the problem? You could have added your issue. You could have made that Excel sheet. You could have made that Excel sheet and had data from your own group, whom you know. You should have raised your own data in comparison to that. Very simple.
सर एक्चुअली मैं आपको अपना थीसिस जो है वो नॉन हेल्थ साइंस के ऊपर और हेल्थ साइंस के ऊपर ही करूँगी इसमें मैं प्री इंटरवेंशन दूँगी तो इसके बाद पोस्ट इंटरवेंशन की कितना उनको नॉलेज क्या है नॉलेज लो
आप वो गूगल शीट स्प्रेड करके आप you can collect the data. I have got very big groups of this allied health sciences. You can put that data there. People will fill up that form. You will get all data at your home only. Very simple. Then you can make comparison that this is the global and this is Indian. Simple.
Yes sir. Next time we will use sir.
Okay. Thank you.
Hello. Good job. Sakshi, first of all, thank you so much that you have chosen antibiotic resistance specifically. See, very relax and starting with the business out there. So the thing is, you see, India is the second largest of the BRICS worldwide, right? And the topic of antibiotic resistance, it is highest in India, and second is South Africa, right? So this is not a question. It is a suggestion that in your suggestion there you are going to write that what are my suggestions to decrease the rate of the antibiotic resistance. Please do mention that antibiotic resistance is due to the drug abuse. Specifically, that had to be taken in the areas like in hospitals. Really, when you write the data for India, I'm specifically targeting on India. Right? So you please do mention therein that the drug abuse happening into the hospitals, clinics, nursing homes, and the small PHCs. This is very much high, and the knowledge has to be given to the experts who are using the drugs, because this is not the patient who is victim. This is the healthcare professional. Hello. Increasing amazes your healthcare and the purchase authority as well of the hospitals. But what happens in India, why the drug resistance is not there, the antibiotic that actually has to be used, it is not being used, but the antibiotic higher than that antibiotic, it is used, and that is why the drug abuse is there. The main reason. Ceftriaxone डालना है empiric में meropenem डाल दो चलाए रखो. That causes resistance. This is a small example. So you do please mention there as well. Coming to the second part, the data for Tanzania, it is a little, it is not that exact, but if you require my help, I will give you the exact data for the drugs specifically which are being used in the South African part, including Zimbabwe, Malawi, your French West, and the southern part of Africa. I will share you the entire, which are the diseases which are prevalent, which are on higher side, and the drugs which are now commonly being used there. I can share you that. That is kind of help I can do. Yes. So thank you so much for your slides for antibiotic resistance. Thanks, Akshay. Thank you.
All poster presentees are requested to start displaying their posters, and the science exhibitors are requested to arrange their models on the first floor of the main auditorium. And next we have Slurman G. Slurman.
Good afternoon, everyone, and welcome to my presentation. My name is Slamen, and I'm a full semester MSc Clinical Embryology student at Tikari University. The title of my presentation is Better Treatment for Male Infertility. Is it clomiphene citrate or letrozole? This is the outline of my presentation. According to the World Health Organization, infertility is the failure of a couple to achieve clinical pregnancy after at least 1 year of regular unprotected sexual intercourse. Globally, about 70 million people suffer from this serious public health issue. In India, it is estimated that about 13 to 19 million people experience infertility. The cause of infertility is multifactorial. It could be environmental, for example, pollution; structural, for example, unaffordable education and health; social, for example, lack of suitable reproductive partners; and biomedical, including ovulation problems in females and reduced fertility in males. Among other causes of infertility, male factors constitute 50%, and these are examples of the causes of male factor infertility: reduced sperm quality, testicular damage, and erectile dysfunction, as well as ejaculation disorder. To relieve the burden of infertility, infertile individuals can opt for lifestyle change, for example, quitting alcohol; assisted reproduction technology, for example, in vitro fertilization, IVF; surgical management, for example, varicose in case of varicose; and medical therapy, including gonadotropins, clomiphene citrate, and letrozole. This study is focused on the use of clomiphene citrate and letrozole in the management of male factor infertility. As you can see in figure 2 and figure 3, CC prevents the negative feedback of estrogen in the hypothalamus and pituitary, while letrozole inhibits the conversion of androgen to estrogen. This is one of the studies on the effect of clomiphene in the treatment of male factor infertility. This is another study according to the literature. Although there are several studies that have investigated the effect of CC and LZL semen parameters, there are conflicting reports, and there is a less number of studies in the Indian scenario. For this reason, the study aimed to compare the impact of clomiphene citrate and letrozole on sperm parameters among men with low sperm count and motility in Punjab. The objectives were to determine the changes in semen parameters before and after CC and LZ treatments, respectively among men with low sperm count and motility, and to compare the difference in the changes in semen parameters between the two groups, both CC and that of letrozole. Hypothesis: the null hypothesis was there is no significant difference between the changes in semen parameters between the CC group and the LZ group, while the alternative hypothesis was there is a significant difference between the semen parameters between the CC group and LZ group. Let's see. This study was conducted by retrospectively analyzing the medical records of patients with low sperm count and motility at Midland Hospital from January 2020 to March 2025. 36 patients were included into the study based on convenience sampling. The inclusion criteria for patients were men aged 21 to 50 years, men having low sperm count and motility, with documented records of both before and after semen parameters, and the doses for clomiphene and that of letrozole were 25 mg clomiphene citrate per day and 2.5 mg letrozole per day. The exclusion criteria included men below 21 years and above 50 years, with other sperm parameters, for example, full sperm morphology and in combination. The 36 patients were divided into two groups, one letrozole and the other clomiphene. 18 patients were in each group. Primary outcome measures were sperm count and motility, while the secondary outcome measures were cement volume, cement pH, and that of the glucoside. All the parameters were obtained by cement analysis according to the World Health Organization 2021 guidelines, and statistical tools included Google Sheets for cleaning the data, MSSL for distributed statistics, and SPSS for inferential statistics. The level of significance was kept at 5%. Looking at the table, according to the first objective of the study, in COVID-19 group, there was a decrease in the cement volume, and for the other parameters, there were improvements after CC treatment. However, the improvements were insignificant in cement pH and glucoside and significant in sperm count and motility. The next table shows the data concerning letrozole treatment. After treatment, there were improvements in all the primary outcome measures and secondary outcome measures in the LZ group. However, the changes or improvements were insignificant as depicted in the p-value. All the p-values were greater than 0.05. The second objective, comparing the difference in the both groups. In terms of sperm count and motility, there were changes in the sperm count and motility. However, the changes were insignificant, as you can see in the p-value column. All the values of p exceeded 0.05. Findings of the study. In the two groups with regard to sperm count and motility, there were improvements. The differences in sperm parameters after 4 weeks were not significant, and for this reason, we accept the null hypothesis. There is no significant difference between the two groups, both CC and LZ. However, there were significant changes in sperm count and motility observed in CC group after treatment. Other studies have confirmed that, for example, Akin and colleagues, Manda and colleagues, while other studies found the similar results like Pascal and colleagues and Guar and colleagues. The study was limited in terms of the lack of data on patient history, the lack of record of hormonal profile of patients. In conclusion, there were changes in semen parameters. In conclusion, there were changes in sperm parameters in both CC and LZ groups. There was higher increase in sperm count in the LZ group, while there was higher increase in sperm motility in the CC group. Although there are similar impacts of both drugs, CC might be more effective. For better comparison, further prospective studies with larger sample sizes are required. These are the references for your review. Thank you for listening, and a special thanks to Raspberry University for organizing the International Conference of Biomedical Sciences. Thank you very much.
Have you considered the parameter during the fertilization? What is the role of donor pellucida proteins, ZP? You must know about ZP proteins.
Yes, we have zona pellucida proteins.
Yeah, so which donor pellucida protein is involved during the fertilization and following which signaling pathway? And what is the role of that signaling pathway during the fertilization?
So thank you very much for your question. It is very important. With regards to the topic of the presentation, we are looking at the treatment for male factor infertility. Which treatment is better, whether clomiphene citrate or letrozole? And looking at the context of your question, I will show light on it, or it's not relevant to this particular presentation. So we have many factors that play crucial role in fertilization, both the male factors and that of the female factors. For example, looking at the male factor, we have an enzyme produced within the acrosomal region of the sperm called hyaluronidase that is responsible to dissolve the layers of the zona pellucida. The mechanism or the synaptic pathway is very complex, and at this particular stage on this particular platform, I can walk you through the entire signaling pathway. You have calcium ion influx, efflux, you have ionocytor release in the eggs. So looking at the passage from the zona pellucida to calcium efflux for activation, I think it will not be of suitability on this platform. So the major concern is the treatment for male factor infertility is a clomiphene citrate or letrozole. And to answer your question in short, there are multiple factors. Number one, the hyaluronidase released by the sperm can dissolve the layers of the zona pellucida in order to allow the sperm to pass through that to activate the egg cells. Thank you, sir.
I am asking simply what is the signaling pathway? The normal pathway following during the invasion. That two sides can fertilizer in the process of invasion. What is the signaling pathway at that time? And
yes.
Which protein, which gatekeeper protein is involved in the invasion?
Yeah, we have many proteins that are involved in that, and like I told you previously, we have the acrosin.
GP3.
Yeah.
Okay, GP3 involved, and that is the simplest pathway, calcium signaling pathway followed the.
Yeah, like I mentioned in my answer, sir, the calcium pathway, and that. For the ZP, so now pellucida protein, we have three. We have ZP1, ZP2, and ZP3. So there are three major ones, not only ZP3. So thank you. Thank you.
Next we have Mitali.
Good afternoon, everyone. Respected heads of the departments, faculty members, dignitaries, judges, and all the delegates. It is indeed a great honor for me to be a part of ICBS 2025 International Conference of Biomedical Sciences, organized by the University School of Allied Health Sciences, Rayat Bahra University, Mohali, Punjab, and to have the opportunity to present my work before such a distinguished gathering. I am a postgraduate student in the Renal Dialysis Department, University School of Allied Health Sciences, Rayat Bahra University, and I am truly grateful for this platform. My topic is psychological impact on the treatment burden in anemia patients undergoing maintenance hemodialysis. That means that means when patients with anemia means low blood cell count, are getting hemodialysis. Hemodialysis means a treatment for kidney failure. They often feel a treatment burden. This includes physical, emotional, and time-related effort they have to put into managing their illness, like frequent hospital visits, strict diet, taking medications, dealing with side effects, etc. The treatment burden can affect their mental health, causing feeling like stress, anxiety, depression, frustration, or hopelessness. So this topic is about studying how all this mental stress and emotional struggle makes harder for these patients to cope up or stick to their treatment. Chronic kidney disease is one of the major non-communicable diseases that is linked to high economic and health burdens globally. The global prevalence of CKD is 13.4% with approximately 4.9 to 7.1 million patients with well end-stage renal disease requiring renal replacement therapy. CKD is becoming a global health issue as the occurrence and spread of ESRD have increased continuously during the past 3 decades. Anemia is an inevitable and common complication of CKD. The World Health Organization defines anemia as hemoglobin concentration less than 13 gram per dl in men and less than 12 gram per dl in women of childbearing age. CKD patients are twice as likely experience anemia compared to those without renal disease, and the rate of anemia tends to increase as the estimated glomerular filtration rate decreases. Patients undergoing hemodialysis are under considerable physical and mental stress. Few studies indicate an increase of psychiatric morbidity in them. Treatment burden is an emerging concept in chronic disease management. Treatment burden is the workload imposed by healthcare on patients which affects on their quality of life. The burden of treatment is focused on unpleasant feelings associated with receiving treatment. The burden care may vary based on the kind of treatment a person gets. Objectives of the study: to investigate the psychological impact on the treatment burden in anemia patients undergoing hemodialysis in association with gender, age, disease duration, and comorbidity. These are the materials and methods which I have used. Study design was hospital-based, cross-sectional and analytical study. Sample technique was purposive sampling. Sample size was 40 anemic patients undergoing maintenance hemodialysis. Sample size estimation was through G-Power software. Age group was 30 to 70 years and the study place was various hospitals in and around Rupnagar, Punjab. Inclusion criteria was patients aged 18 to 60 years of age undergoing maintenance hemodialysis treatment for at least 3 months. CKD stage 3 to 5 dialysis patients. Anemic patients undergoing maintenance hemodialysis. Clinically stable patients. And the exclusion criteria was patients with acute kidney injury, patients with age below 18 years, recent blood transfusion within the last 3 months, and patients who has undergone renal transplantation. Methodology: the patients were interviewed when they were comfortable and only after the dialysis procedure was over. A specially designed performer was used to document background details and socio-demographic profile, clinical examination and investigation findings. Psychiatric comorbidity was assessed by administering schedules for clinical assessment in neuropsychiatry. The psychiatric diagnoses were based on the International Classification of Disease, diagnostic criteria for research. Hamilton Depression Scale was used to assess depression. A treatment burden questionnaire was used to assess the treatment-related burden in study participants. The questionnaire was observed from Murphy Research Trust. The statistical analysis. Data were collected, compiled, and tabulated. Results were statistically analyzed using the statistical package for the Social Science version 21. Parametric data were analyzed using paired and unpaired pretest. Frequency data were analyzed in chi-square test. Results and discussion. The table number 1 showed the gender-wise distribution of the patients, and the patients were predominantly males, that were 72.5%. Table number 2 showed the demographic characteristic of the chronic kidney disease patients undergoing dialysis. The maximum percentage is 57.5% of age group in patients fall between 41 to 60 years of age, and the maximum patients were 40% were recorded as illiterate. Table number 2b showed few more demographic characteristics of the patients. The maximum patients were 72.50% were unemployed. So far marital status is concerned, the maximum patients were 60% were married. The maximum patients 47.50 falls in the monthly income group of 5,000 to 10,000. Table number 2c demonstrated few more demographic characteristics of the patients in comorbid physical disorders. The maximum patients 47.50 were with diabetes mellitus in psychiatric comorbidity. The maximum patients 52.50% were with adjustment disorder followed by depression. For the duration of chronic kidney disease, the maximum duration was 40% were recorded between 0.5 months. Table number 2d showed Few more demographic characteristics of the patients. For the duration of dialysis, the maximum patients 50% conducted the dialysis for more than 3 months. For the frequency of dialysis, the maximum patient 65% conducted dialysis thrice a week. In funding treatment, 10% patients were non-sponsored. Table number 3 showed Hamilton Depression Scale scores of chronic kidney disease patients undergoing dialysis. A total of 18 patients were recorded with psychiatric disorder. Table number 4 showed the association between treatment burden in CKD and psychiatric illness. The maximum patient 61.11% were the high burden followed by moderate burden 27.78% and the least 11.11% with low burden. However, high significant association was found between treatment burden and psychiatric disorder in patients. Table number 5 showed the association between sex, education, occupation, income, frequency of dialysis, and treatment expenses with psychiatric illness in chronic kidney disease patients undergoing hemodialysis. Statistically, no significant association was found between psychiatric illness and gender, whereas highly significant association was found between psychiatric illness and education. Further, statistically significant association was found between psychiatric illness and occupation. This is the conclusion. Psychiatric comorbidity was significantly higher in CKD patients undergoing hemodialysis. Psychiatric comorbidity was more common in males in the age group of 41 to 60 years. The most common psychiatric comorbidity in CKD patients undergoing hemodialysis was with adjustment disorder followed by depression. Patients with recent onset dialysis are significantly more prone to develop psychiatric disorders, and high impact of psychological complication on treatment burden was established in patients with anemia undergoing hemodialysis. These are the references. Thank you so much.
Any questions?
You said exclusion criteria is less than 18 years, right? Exclusion. But वहाँ पे आपने age group जो लोग 30 से onwards लिया है. So exclusion में 30 से नीचे वाले सारे excluded हैं. What my point? You have written that you have taken the age group from 30 years to from 20 to 30 कितना लिखा हुआ है?
18 to 60 years.
It's a wide range, isn't it?
Yes,
आपने 18 नहीं लिखा हुआ, आपने वहाँ पे कुछ और लिखी हुई है. See your slides. But when you have taken the exclusion, उसमें आपने less than 18 years लिखा हुआ है इसमें. देख लेना, ठीक है?
Hello. You give definition that anemia happens when blood cells don't receive oxygen, right? Can you explain how? How our blood cells, like hemoglobin, how? How our hemoglobin can't receive oxygen? Can you explain?
I didn't mention it, sir.
We're talking about anemia, right?
Yes.
Can you explain how it happens in our body?
Anemia happens when there is low blood cell count in our body.
Low blood cell,
Yes.
right?
Red blood cells, red blood cell. Red blood cell. When there is low red blood cell count in our body.
It's right definition you give us.
Neha,
Good afternoon, everyone. We are holding the session for a moment. Our guest faculty, invited speakers are here. So I request our Dean Sir, Professor Dr. Pankaj Kaul Sir, uh, to come onto the stage.
I would request Professor Pankaj Kaul to escort Professor Sunil Arora, former HOD, Immunopathology and Regenerative Medicine, to felicitate the speakers of today's session. I would request Dr. Mukesh Thakkar to come on the stage. Dr. Thakkar had delivered an expert talk and conducted an interactive session on crime scene investigation. Dr. Thakkar? Okay. I request Dr. Suchitanand Singh to come on the stage. Sir delivered an expert talk on optometry and technology.
मैंने उनके लिए माइक
Thank you, sir. I now request Mr. Sohail Anjum to come on the stage. Sir delivered an expert talk on operation theatre and anesthesia technology. Thakkar sir has joined us. I request Professor Mukesh Thakkar to come to the stage. Professor Thakkar had delivered an expert talk and conducted an interactive session on crime scene investigation. I would request Mr. Muntazir Rashid to come on the stage. Mr. Rashid delivered an expert talk on renal science and dialysis technology. I now request Professor Pankaj Kaul to present a bouquet to Sir. Thank you, sir, for your kind cooperation. We would now resume with the oral presentations. The next participant can please come on the stage.
Good afternoon, respected chief guests, teachers, and my dear friends. It is an honor to stand in front of such an esteemed gathering today. My name is Neha. I am from Riyadh Bhara University pursuing MSc Forensic Science. Today I am here to present my work on study of ink diffusion on paper using water sample from different geographical regions. This study focuses on how different ballpoint inks behaves on different papers when exposed to water, a subject that holds significance in forensic document examination. This study explores how different inks on various paper react when exposed to water over time. We have used 6 types of pen and papers, immersed them in water from 3 regions, Mohali, Chandigarh and Himachal Pradesh for 5, 10 and 15 days. We then analyze the changes using a video spectral comparator VSC. The result shows some ink faded and not completely the ink disappeared, highlighting the durability of modern ink in water exposed documents. In forensic science, question documents are often exposed to environmental damage, especially water. This study mimics such condition to help experts better understand ink behavior during real-world exposure. Composition of water. We analyze water from different geographical regions, Mohali, Chandigarh and regions in Himachal Pradesh that are Jogindanagar, Sundarnagar and Palam. Mineral content, pollutants varies by region to region, which can influence how ink dissolves or spread in paper. So understanding the variability was central to our research. Materials and methodology. We used 6 different pens and 6 different A4 paper types. That gave us 36 combinations. Each was immersed in water samples for 5, 10 and 15 days, giving us a total of 180 samples. After immersion, the samples were air-dried, labeled, stored in transparent envelope. We analyzed each visually and then using a video spectral comparator. Here's an example of our labeling. P1, S1, D5, W1 means paper 1, sample 1, immersed for 5 days using water sample 1. This helped us to systematically track our data on pen paper water combination. Material used. Our pen range from Montex to Cello and Flair brands. The paper used are of GSM 70 gram per meter square to 140 gram per meter square. Water was collected from Mohali, Chandigarh and 3 towns in Himachal Pradesh, Jogindanagar, Palampur and Sundarnagar. Regional relevance. Regional variation on water was crucial because it mimics real-life exposures such as documents submerged during floods or stored in different tap water conditions. Variability in water quality significantly affects how it behaves. Instrumentation. We have used video spectral comparator. It works on the principle how ink absorb and reflect light across various wavelengths. This non-destructive tool allowed us to detect ink fading, dispersion and any obliterations which may not be visible to the naked eyes. Here are the results. Our results were tabulated based on observation after 5, 10 and 15 days. At 5 days, all samples remained intact with no visible change, no visible fading. After 10 days, minor fading was observed. After 15 days, noticeable ink dispersion began, but text remained legible. We used a semi-quantitative plus system to score ink stability, with more plus indicating better stability of the ink. Here are the images of the documents. Conclusion. Ink from common pens remains stable up to 15 days in water due to modern ink composition. This can help forensics experts analyze documents from water-related crime scenes. Our grading method also provided a simple way to track visual changes. Thank you. Next we have Gunjan.
Good afternoon, respected chief guests, teachers, and my dear friends. My name is Gunjan. I am from Riyadh University, pursuing Masters in Forensic Science. Today, I am here to present my work on the topic Effect of Water Exposure on Ink Dissolution. Document examination plays a crucial role in document authentication and fraud detection. Document can be physical or digital. It serves as a proof as it is a key aspect for forensic science. Forensic science is the use of the scientific method and knowledge to help to solve the crime and assist in legal matter by analyzing evidence from crime scene. The examination process begins by identifying the tool used to create a document, pen, printer, then a visual, physical and chemical analysis. Ink vary in composition that helps to determine the ink type, source and age. Water significantly impact both ink and paper, resulting in ink degradation of paper. Ink and degradation of paper. Paper is made up of cellulose fiber as because it absorbs water, leading to weakening and swelling of the paper. This study tells us how ink and paper behave when exposed to water. These are the different materials that we have used. These are 6 different types of pen, paper, water sample from 3 different regions and transparent disposable glasses for as containers. These are the pen that we have used. These are Montex Prima, Montex Mega Pen, Cello, Simply Ball, Unomax, Classmate and Flair. These are the different types of paper that we have used, that are Sirpur, Spectra, JK Copier, Audi, AA and JK Cedar. These all paper have the GSM that is in between 70 to 100. The method that we have used, we have taken 6 different ball pens along with 6 different papers. Then with all the ball pens, we have written on each of the paper. That makes a 36 number of total sample. Then each sample was immersed in the water for different time intervals. That is 5 days, 10 days and 15 days. Then these sample was removed and then air dried at room temperature and examined under VSC. That is video spectral comparator. This is the method that we have used. This is how we have kept the sample for different time intervals, that is 5 days, 10 days and 15 days. The instrument we have used for this process is VSC, that is video spectral comparator. It is manufactured by Foster and Ferrell. It is primarily used in examination of question document. It allows us a non-destructive analysis of documents using a wide range of light sources. It works on the principle of interaction of electromagnetic radiation and different material. It analyzes how ink and paper absorb, reflect and fluorescent light, works under fluorescent light under different wavelengths. The light source that VSC uses ultraviolet light that detects fluorescent ink and chemical alteration. Visible light that allows to see the true color of image. Infrared light that reveals the underlying text that is not visible clearly in some cases. As you can see in this picture, this is VSC that we have used. These are the results from different days, different time intervals, 5, 10 and 15 days. After soaking samples in water for up to 15 days, we have observed that writing did not entirely disappear. In most of the cases, ink remained legible without any magnification. This tells us that modern inks have good resistance to water. Paper quality also plays a very important role, as in some cases paper was turned and in some cases it gets weakened. These are the results of different pen type and paper. This is for pen B, pen C, pen D, pen E. This study tells us the exposure of water. Writing done with modern ball pen remains partially or fully readable. This can be used in forensic investigation involving damaged documents, detect forgery, authentication, determine the age of ink, authentication, documents linking to evidence. In suicide cases, most of these things are used to verify the authenticity of the paper, as to get to know that the suicide note was written by the person or not. At the end, I just want to say ink and paper analysis helps forensic scientists uncover the hidden story behind a document, whether it is proven the authenticity, detect or even link it back to suspect. It turns the ordinary sheet of paper into a key piece of evidence. Thank you.
Why you both are using the same kind of work?
Sir, we have done this work together.
Have you also used cellulose membrane? Cellulose membrane?
So what are you saying?
No. Cellulose membrane.
Membrane cell.
Yeah, it's also for paper quality. Do you not know? Okay, please. Go ahead.
Thank you. Now let's welcome Mayank Man.
Good afternoon, everyone. I'm here to present my work title, From Health to D-Peptide, Unlocking Antimicrobial Mechanisms Against Drug-Resistant Pathogens. In this presentation, I'll be discussing how we have investigated the role of synthetic antimicrobial peptides, particularly their ability to inhibit multi-drug resistant pathogens, while they are able to safely maintain their biocompatible nature and their property to be useful in future biomedical applications. So we know that, I'm assuming that everybody is familiar with antimicrobial resistance and how it has become a global health concern due to the widespread use, the widespread unregulated use and misuse of antibiotics in today's healthcare industry by not just the professionals but also the patients. So it has led to the development of antimicrobial resistance. The recent COVID-19 pandemic has not only highlighted but also worsened the scenario of current antimicrobial resistance globally. So our solution is to explore innovative antimicrobial formulations which are not only effective against against a wide range of pathogens, but also they are biocompatible and safe to use. So in this realm, antimicrobial peptides, particularly synthetic antimicrobial peptides, are a topic of study, is a topic of fascination in this world of antimicrobial agents due to their majorly due to their ability to provide a broad spectrum antimicrobial action and having a reduced propensity to develop resistance against pathogens while being safe for use. However, uh, a major challenge lies in their stability, that is their degradation in the presence of physiological conditions like the presence of various salt, various trypsin, various proteases in the body. So in this study, in this work, we have investigated a template-based design of synthetic peptides. In this study, we used synthetic peptide DP1, which was already characterized for its antimicrobial activity, and we explored template-based design by formulating two distinct peptide analogs. The first one is a BDP1, which was terminally using the template that is DP1. We capped its terminals, that is the NNC terminals, with acetyl and amide group as a possible way to provide the peptide with resistance towards degradation. And in second analog, we flipped the peptide DP1 into its enantiomeric form, that is a DDP1. So it was composed entirely from L amino acid residues to D amino acid residues. Then we comprehensively assessed its in vitro activity by investigating its antimicrobial activity, biocompatibility, structural determinations. So as you can see in this table, the peptide DP1 and and DDP1, they were evaluated for antimicrobial activity against a wide range of pathogens, including gram-positive bacteria, gram-negative bacteria, including their drug-resistant variants, as well as nosocomial, that is the clinical isolates. So we can clearly see in this table that the activity of the novel peptide, that is the DP1, was significantly higher than the parent peptide DP1, which the peptide DDP1 shows minimum inhibitory concentration, that is the MIC, as low as 1 micromolar, and it just ranges up to 8 micromolar, whereas the peptide DP1 starts from 8 micromolar and goes up to 64 and even 128 for some tested concentrations. Even it was even effective against a fungal strain, as it's not visible downstairs, but we also studied C. and lichen strains. So the peptide DDP1 was also able to effectively inhibit its growth. Next is the stability analysis. As I mentioned, the peptides, the antimicrobial peptides, not just the antimicrobial peptides, but also the antimicrobial agents. The major hindrance in their clinical translation is their reduced activity in vivo settings. That is, their activity is reduced when they are exposed to various trypsin concentrations in the body. So we tested various these peptides against various rise or varying trypsin concentrations for all the peptides. As we can see in these tables, that the peptide DDP1 was able to maintain its activity even at highest concentrations of trypsin, while the peptide DP1 was technically ineffective against rising concentrations. Okay, I'll just quickly wrap up. So we also studied the stability under physiological salt and serum concentrations. The peptide DDP1 was able to maintain its activity over there as well. And then we studied the biocompatibility of the peptide. Here we can see that up to 128 micromolar the peptide was able to maintain its activity. And since the peptide's antimicrobial activity stayed at 1 micromolar, 2 micromolar, 4 micromolar, so the therapeutic window was quite large to consider the 128 micromolar window. we can see over here that the peptide was completely effective against S. aureus bacterial cell as seen by FSM study. The peptide's action completely destroyed the morphology of S. aureus cells. Um, Apart from that, wound healing assessment was done for the peptide and it showed that the peptide had wound healing effects as seen by this image. Further, CD spectroscopy of the peptide was done and peaks at 208 nanometer and 225 nanometer indicates the presence of alpha helical structure indicating the stability of the peptide. To conclude, we developed small cationic peptides and these peptides exhibited significant enhanced antimicrobial efficacy while maintaining minimum hemolytic and cytotoxic profiles. Additionally, they were multifaceted peptides able to promote cell proliferation and maintain their antimicrobial effectiveness. The peptide DP1 is currently under the process of being patented by the current ongoing work with ICMR. Thank you.
How big is this peptide?
Ma'am, it's 15 amino acids. 15 amino
15.
acids. We are actually not allowed.
So what criteria did you take to synthesize this?
Ma'am, we maintain a balance between the amphipathic nature and the helical nature of the peptide. Actually, we are not allowed to disclose the sequence of the peptide because of
It's okay. But you must have taken some
yes, ma'am.
base to synthesize
Yes, ma'am. We started with cathelicidin peptide, the NCath2 peptide, which is a chicken cathelicidin peptide. And since it is already quite established for its antimicrobial effectiveness against even fungi, virus, not virus, fungi and wide diverse range of bacterial pathogens. That's why we choose that peptide, and from that peptide we developed DP1. However, DP1 had antimicrobial activity.
But you are saying it is hemolytic also?
No, ma'am, not hemolytic. I would say it's more unstable in the presence of physiological conditions like salt concentrations, serum concentrations, and as such.
But there are certain Bacillus acnes and Bacillus acnes and other bacteria which are producing antimicrobial peptides. So have you studied that? Gramicidin, surfactant, and
No. We are just working. For now, we are working on developing synthetic antimicrobial peptides. We're not working on the natural antimicrobial peptides for now, because as we have seen in our studies that most of the natural peptides they lack in stability, although they are superior.
No, small peptides they do not lack in stability. I worked on that. It's not. It's a 7 amino acid peptide or 10 amino acid peptide. They are not using.
Yes, ma'am. Right now we are even working on shortening the 15 amino acid sequence. So we are working on that, but I have not worked on that.
You have just in DP1 and DP2. What software you are using for modeling?
Sir, modeling right now I have not done the modeling part. Although I am continuing the simulations part, I am using Gromax for that thing.
And what was your reference drug?
Sir, my reference drug was earlier it was DP1, then it was MCAT2, but we are not using a standard drug for that because our work is already published.
How will you decide the resistivity or sensitivity of particular microorganism?
Sir, could you please repeat the question?
If you are not considering antibiotics,
sir, I have studied the antibiotics as well and I published that as well, but I thought that since I'm just presenting the peptide work here, so I did not include that part. But I have studied the comparative analysis of peptide and the antibiotics as well. I have done that.
And just two questions more.
Yes, sir.
You have said your peptide was cationic. Okay?
Yes.
So, how you will define, how you have decided this is cationic?
So because it has positively charged residues in the sequence, it has lysine and arginine in its peptide sequence.
Saying you are taking amphipathic molecules.
Yes.
You are trying to take amphipathic molecules.
Yes, ma'am.
So,
yeah, ma'am, because it has a balanced charge and.
You are also adding some fatty acid to this?
No. Only the amino acid residues. That's all.
Do you know the isoelectric point of that peptide?
Sir, I am not able to remember that right now, but I did study it when I was studying the initial design of the peptide.
And from the isoelectric point you will get all that. Okay. And which cell line is for fatty acid?
Sir, I've used Rho 264.7 macrophages, and as well as I have also used PBMCs, peripheral blood mononuclear cells. Yes, sir. Okay, thank you so much.
Next, Aditi Rana. A very good afternoon to all. My name is Aditi Rana. Today, my topic is investigation rise in incidences of necrophilia. So here are contents. Introduction of necrophilia, that what is necrophilia, its historical background, objective, classification of necrophilia, case studies, factor affecting of necrophilia, and at last conclusion. Necrophilia is a paraphilia, or you can say it is a mentally disorder or abnormal sexual desires that is that involves a person doing sex with a corpse or dead body. He feels satisfaction or gratification by doing this. In this picture, a person digging up into grave for a dead body. Historical background. पहले क्या होता था कि जैसे सेलर्स होते थे जो बोट पे काम करते थे, शिप पे काम करते थे, तो ऐसे किसी की डेथ हो जाती थी, उनकी फैमिली में किसी की डेथ हो जाती थी, फ्रेंड्स की डेथ हो जाती थी, तो वो क्या करते थे, उस डेड बॉडी को वापस लेके जाते थे, तो कई दिनों तक अपने पास ही रखते थे। तो वहाँ से क्या होता था कि डेड बॉडी पास में है, तो फिर डेड बॉडी के साथ ही उन्होंने ये चीज़ शुरू कर दी, सेक्स करना स्टार्ट कर दिया। तो वहाँ से ये चीज़ सामने आई और उस वजह से वहाँ से पता चला कि ऐसी भी कोई डिजीज़ होती है। You can see in this picture. The objective of this study, it provides an overview of current knowledge on necrophilia and the various case studies involves necrophilia. Here are 10 tier classification of necrophilics. First one is role player. Role player में क्या होता है कि कुछ लोग फैंटेसी होती है कि वो क्या करते हैं कि अपने पार्टनर के साथ उसको डेड ऐसे करके कि ये डेड है तो उसके साथ सेक्सुअल एक्टिविटी करते हैं। सेकंड वन अपॉर्चुनिस्टिक नेक्रोफिलिक्स, कि अगर उनको डेड बॉडी मिल रही है तो क्या करेंगे कि वो उसके साथ ही सेक्स करना स्टार्ट कर देंगे। कुछ शमशान घाट में क्या होता है कि कुछ लोग जो वहाँ पे होते हैं गार्ड वगैरह, तो उस केस में बहुत देखा गया है। एंड देन नेक्रोमल्टीलोमा मिक्स एंड देन फैंटेसाइजर, romantic necrophilia. These are the various classification of necrophilia: tactile necrophilia, homicidal, exclusive. So this is the chilling case of necrophilia in India. लिथारी हत्याकांड के बारे में सबने सुना ही होगा। उसमें क्या होता है कि ये हुआ था बेसिकली नोएडा में सेक्टर 31 में। वहाँ पे क्या हुआ था कि बहुत दिनों से, लगभग 2 सालों से बच्चे गायब हो रहे थे। तो पता करने की कोशिश कर रही थी पुलिस, तो पता चल नहीं पा रहा था कि क्या रीज़न है, कहाँ बच्चे गए।
तो फिर करते करते इन्वेस्टिगेशन पता चला कि वहाँ पे एक D5 बेंगलोर में, जो कि वेरी रिचेस्ट बिजनेसमैन मोनिंदर सिंह पंदेर का था, और साथ में इसका एक सर्वेंट था। वो दोनों मिलकर क्या करते थे, वो बच्चों को गायब करते थे, और गायब करने के बाद क्या करते थे, पहले उनके साथ रेप करते थे, उनको फिर मर्डर करते थे, और उसके बाद अगेन उनकी डेड बॉडीज के साथ क्या करते थे, फिर से रेप करते थे। और कई बार तो उन्होंने क्या किया है कि जो फ्लैश होता है डेड बॉडी, तो उन्होंने उसको खाया भी है, दैट इज अंडर कैनाबिलिज्म। तो इसमें पाया गया कि a total of 627 body parts were found from the canal। बेंगलोर के पीछे एक कैनाल थी, वहाँ पे देखा गया पॉलिथीन के अंदर कुछ डेड बॉडीज के रिमेन्स थे, स्केलेटन रिमेन्स बेसिकली, जैसे स्कल हो गई या हैंड हो गया, फुट हो गया, इस तरह के कुछ स्केलेटन रिमेन्स पाए गए। और वहाँ से पता चला कि ये 627 बॉडी रिमेन्स है इसमें इन्वॉल्व है। तो वहाँ से पता चला, इन्वेस्टिगेशन हुई, और फिर उनको नार्को एनालिसिस परफॉर्म किया गया वहाँ पे, और उसके बाद से पता चला कि इनको मतलब ये साइकोलॉजिकल डिसऑर्डर है। बहुत सारे केसेस है फेमस जो आए हैं, तो इस रिव्यू पेपर में मैंने 2019 से 2025 तक के केसेस लिए हैं। सारे केसेस तो मैं इंक्लूड नहीं कर पाई इस पीपीटी में, बट कुछ मैंने जो फेमस केसेस हैं जिनकी जजमेंट पास हो गई है वो मैंने इंक्लूड की है। Factors affecting factor can be anything like socially, psychologically and biologically also। Socially कुछ बच्चे होते हैं जैसे घर पे टॉर्चर हो रहे हैं, या फिर क्या होती है उनकी एंटी सोशल पर्सनैलिटी होती है, उस केस में क्या होता है अकेले रहते हैं तो दिमाग में कुछ भी आता है, ठीक है। और कहीं 2-4 पेपर में मैंने देखा कि उसमें दिया गया है कि न्यूरोलॉजिकल भी कुछ डिसऑर्डर हो सकते हैं, कि उनका जो ब्रेन में जो न्यूरोलॉजिकल स्ट्रक्चर है उसमें कुछ डिफरेंस आ रहे हैं, उसकी वजह से ये नेक्रोफिलिया की तरफ जा रहे हैं। कंक्लूजन, एक्चुअली क्या होता है कि इस तरह के टॉपिक्स पे कोई बात करना पसंद नहीं करता, बट आजकल की यंग जनरेशन को इसके बारे में जागरूक करना बहुत ज़रूरी है, उनसे बात करना बहुत ज़रूरी है, डिस्कस करना बहुत ज़रूरी है इन सब चीज़ों पे, ताकि उनको पता चले कि अगर ऐसा कुछ है तो उसके लिए उनको थेरेपीज दी जाए, साइकोलॉजिकली उनके सेशंस लिए जाएं। उससे क्या होगा कि नेक्रोफिलिया जो है उसके केसेस आने कम हो जाएंगे। Here are the references. Thank you.
So do you think these kind of should be taken to psychologists, psychiatrists or neurologists?
मैम अकॉर्डिंग टू मी साइकोलॉजिस्ट के पास लेके जाना चाहिए। एक्चुअली क्या होता है ना, आज के टाइम पे सब लोग फ़ोन में इतने बिजी हो जाते हैं कि अपने ही परिवारों के साथ बैठने का टाइम नहीं होता, अपने बच्चों के साथ बात करने का टाइम नहीं होता। तो आई थिंक उनसे खुल के बात की जानी चाहिए। पेरेंट्स के पास टाइम नहीं होता बिकॉज जॉब भी होता है, सब कुछ होता है, तो उनको साइकोलॉजिकल सेशन अगर दिलवाए जाएंगे, थेरेपी दिलवाई जाएंगी, वो खुल के बात करेंगे, अपने फियर्स के बारे में बोलेंगे।
डाटा कितना है, कितना परसेंट ऐसी एक्टिविटीज वाले लोग प्रेजेंट हैं?
मैम एक्चुअली क्या होता है ना कि हमारे पास तो जो एनसीईआरटी के पास डाटा है वो जो ऑफिशियली मतलब कि केस फाइल किए जाते हैं वही आता है, लेकिन बहुत सारे ऐसे केस होते हैं जो कभी फाइल होते ही नहीं, ठीक है। तो वही करता है ईयर टू ईयर, बट अगर कंपेयर करें 2019 से 25 के बीच में तो मैम बढ़ते ही जा रहे हैं केसेस।
And
हेलो, गुड आफ्टरनून मैम। गुड आफ्टरनून मैम, मुझे आपसे ये पूछना है कि बेसिकली आई माइंडसेट क्या होगा क्रिमिनल का, आप कैसे पहचान लोगे? कि हाँ वो नेक्रोफिलिया है उस पर्सन को।
नेक्रोफिलिया को ऐसे तो पहचान नहीं सकते जब तक कुछ हो ना जाए, इस तरह के केस कुछ सामने आ ना जाए उनकी एक्टिविटीज़ के अकॉर्डिंग। एक्चुअली मैंने जो क्लासिफिकेशन बताई है उसमें क्या होता है कि अब सबकी अपनी अपनी फैंटेसीज होती है, ठीक है। उसमें कई बार क्या होता है कि वो क्या करते हैं, कुछ ऐसी एक्टिविटी शो करते हैं कि वहाँ से पता चल जाता है, जैसे डेड बॉडी के साथ ज़्यादा इन्वॉल्व होना। अब मैंने जो कुछ केसेस बताए हैं उसमें क्या किया गया है, एक पर्सन है 22 ईयर्स ओल्ड, मुझे लगता है वो बच्चे की उम्र है, और उसने अपनी मदर के डेड बॉडी के साथ रेप किया। तो इस तरह की चीज़ें जो है वो कभी भी नज़रअंदाज नहीं करनी चाहिए। साइकोलॉजिकली इन्वॉल्व होना चाहिए अपने बच्चों के साथ और अपने लव्ड वंस जिनको भी आप प्यार करते हो उनके साथ इन्वॉल्व होना चाहिए। उनके दिल की बातें बाहर आएंगी तो उनको सेशन भी दिलवाए जा सकते हैं, थेरेपीज भी दिलवाई जा सकती है, तो यहाँ से अवॉइड कर सकते हैं।
But ma'am, I still wanna ask you one thing. आपने जैसे बोला कि कम्युनिकेट करना चाहिए, अपनी फैमिली के साथ टाइम स्पेंड करना चाहिए, एवरीथिंग इज गुड, ओके फाइन। बट आप मुझे ये चीज़ बता रहे हो, एक बच्चे ने अपनी लाइक मदर के साथ जैसे उसने रेप कमिट किया है ना, तो आप ये भी चीज़ एक तरीके से बता रहे हो कि वो फ्लैश दिखा रहे हैं।
नेक्रोफिलिया इज नॉट कंसिडर्ड एज रेप। Yes. Rape is different and necrophilia is different. Basically, it is categorized as psychological disorder. Okay?
मैम आपको क्या लगता है कि लाइक एक पर्सन जो है जो नेक्रोफिलिया है तो उसको पनिशमेंट मिलनी चाहिए या नहीं मिलनी चाहिए? क्योंकि आपने कहा कि ये साइकोलॉजिकल डिसऑर्डर है और लीगली देखा जाए तो मेनली साइकोलॉजिकल डिसऑर्डर जिन्हें होते हैं उन्हें सिर्फ लाइक वो कर दिया जाता है, कैसे उन्हें सिर्फ कि सुधारने के लिए भेज दिया जाता है, काइंड ऑफ हम ये कह सकते हैं। तो आपका क्या पर्सपेक्टिव है इस चीज़ पे कि उन्हें पनिशमेंट देनी चाहिए या नहीं देनी चाहिए?
पनिशमेंट का तो ऐसे है, देखो मैं तो कोई होती नहीं वो ऐसे बताने वाली है ना, जो लॉज में है लिखा हुआ है उसको फॉलो करना चाहिए। बट मैं इतना कहूँगी कि उससे पहले मतलब जैसे पता चल जाता है, पता चल जाता है कि एक्चुअल में लाइक ये साइकोलॉजिकल डिसऑर्डर है या फिर ये चीज़ जानबूझ के की गई है। जो नार्को एनालिसिस हम टेस्ट परफॉर्म करते हैं वो इसीलिए परफॉर्म किया जाता है, उसमें एक्चुअली एक ड्रग दिया जाता है दैट कॉल्स एनेस्थीसिया, ठीक है। तो एनेस्थीसिया दिया इट मीन्स सोचने समझने की जो क्षमता है वो कम हो गई इंसान की। तो उस केस में वहाँ से जब उसे क्वेश्चंस पुट किए जाते हैं तो डॉक्टर्स एक ओपिनियन बना के देते हैं, तो वहाँ से पता चल जाता है एक्चुअली ही इज फेसिंग दिस साइकोलॉजिकल डिसऑर्डर और नॉट, वहाँ से पता चल जाता है, ठीक है। और अगर किसी ने जानबूझ के किया है तो वहाँ से कहीं ना कहीं पता चल ही जाता है। बट 100% कुछ भी नहीं होता, इसको मतलब कि कोर्ट में एज अ कोरोबरेटिव एविडेंस एक्सेप्ट किया जाता है, लाइक 100% तो कुछ नहीं है। उसके अलावा और भी बहुत सारी चीज़ें होती है, कोई भी क्राइम सीन है वहाँ पे वेरियस टाइप्स के हमारे पास एविडेंस होते हैं, ठीक है। तो क्या किया जाता है, किसी भी केस को सॉल्व करने के लिए हर एक एविडेंस को लिंक किया जाता है, कड़ियों को जोड़ा जाता है, सीआईडी देती है ना।
मैं खुद एक फॉरेंसिक
बहुत अच्छा, ठीक है। फिर तो आप समझ सकते हो कि कैसे चीज़ों को जोड़ा जाता है और उसके बाद एक फाइनल ओपिनियन बनाया जाता है वेरियस पर्सपेक्टिव्स को देखते हुए।
थैंक यू मैम।
Thank you. Next we have Pratibha.
Respected chief guests, teachers, and all my lovely audience, Namaste. I, Pratika, standing in front of you from the Pathology Department. My topic is comparative study of frozen sections in operating cytology and histopathology of neoplasm. So, today we are discussing what does this why mean? Why we are using frozen sections? If there is any difference between the frozen section or touch imprint cytology. So we are comparing the data of frozen section and touch imprint cytology. So if there is any difference, then what is the difference between them? Okay?
माइक थोड़ा ऊपर करेंगे प्लीज।
if there is any difference between the frozen section or imprint cytology and histopathology. So we are comparing the data. Is the accuracy of these both are same, sensitivity, specificity is same or not? So as we are moving towards the modernization, we have seen that the women's, every third woman is suffering from abdominal pain, irregular menstrual cycles or hair fall. These are the early symptoms we can notice in every patient of ovarian neoplasm. So we can't ignore them for the aspects. So what is ovarian neoplasm? This is two terms. The one is ovary and second is neoplasm. Ovary means it is a female reproductive organ which produces ova in every month, okay? And neoplasm means tumor. Whenever there is the proliferation of the cells in the body, proliferation means the cluster of cells forms in our body. That forms tumor. Tumor means the nucleus cytoplasmic ratio will be increased, the morphology of cell changes from the normal cells. So, ovarian neoplasma are the heterogeneous group of benign and malignant tumors. It can vary from surface, germinal epithelium or stromal origin. I can't be distinguish it between on the basis of radiological reports or clinical reports. So here frozen section plays an important role to distinguish between benign or malignant cells. So whenever there is a tumor in between the epithelial lining of ovaries, then it will be called as epithelial ovarian cancer. Whether if the tumor is formed in the stromal cancer, then it will be defined as stromal cancer. And if other the tumor is formed in the germinal cells, means that produce ova further, that is called germinal cell cancer. The aim and objective of the study is here I am comparing the data of frozen section histopathology. Is the accuracy of frozen section or the touch imprint cytology is the same or not? The next one is, are the frozen section or touch imprint cytology plays important role in tumor neoplasma or not? So the study design is, it is a retrospective study where I have taken the 75 cases. So whenever we are receiving the tissue for the frozen section or touch imprint cytology, it will be received without formalin. Only the touch imprint cytology or the frozen is processed if the specimen is frozen or unfixed. Means it doesn't contain 10% formalin in the container. So when the specimen is received, firstly the gross examination conducted by pathologist, the dimensions are noticed by it and examined. So it will take only 10 to 15 minutes for the reporting, and total we have time for 40 minutes because the patient in the OT and the operated, and we have to report for the 40 minutes in between. That's why the result of imprint cytology, frozen section and parabol sections are recorded as borderline, benign or malignant. We can divide it into benign, malignant or borderline cancers. The results will be, as we have taken the 75 samples, out of which 57 lesions are benign and 18 are malignant. Malignant means it can transfer from one place to the another place of the body. Okay, then table number 1 and table number shows that the imprint cytology and the frozen section and diagnosis of ovarian neoplasma. As we can here see, total we have 75 samples, out of which benign is 57, and when we compare the same data with the histopathological report, the same data is obtained from histopathological report, as the benign is 55 and the malignant is 2. The same number in the table number 2, where we are comparing the data of frozen section with the histopathological report. The benign is 57 and the histopathological report is 55 and malignant is 2. So here we can say that the touch imprint cytology and the frozen section are the same, but the difference is if we have not that financial stability, as we can technicians, so we should provide that patient safety first. So we can use the touch imprint cytology for the reportings. Here is also we can use that. This is the images that we can show that there is no difference between this, but we can use touch imprint cytology for the reportings. It is an cystinocardinosoma where we can compare the entrance smears and the histopathological reports. There is the comparison between the frozen section and the final pathological report where I can distinguish between the benign, malignant or borderline tumors. Conclusion is the histopathological report is the gold standard, but for the surgery of the patient, we can use the touch imprint cytology for the reporting, as it provides the borderline or it provides the guidance for the surgeon to operate during surgery. Thank you. At last, I only want to say that eat healthy food and make the nation cancer free. Thank you.
So you think that primary pathology and frozen samples, what did you say in the end? That they are equally important and they are comparative. Is it that?
Yes. As we know that, yes, histopathology is the gold standard. But let's suppose if I have surgery in any hospital, or the surgeon can guide me, because there is a difference between the data of the report. The histopath report will be obtained after 10 to 12 days minimum. But if we perform the same specimen without formalin, we can take report in 10 to 40 minutes, and that will help the surgeon to operate that time only to improve the extra level of the patient.
What do you think about AI that we have been talking yesterday also? So do you think that this can fasten the results?
AI, actually the histopathological lab, most of the work is manually done. We can't be reported the patient's cancer on the basis of AI only. It can help a lot. There are various machine automated tissue processors we have, autosteamers we have, but we have to manually work through.
Last question. What is the role of beta-adenine and integrin in human cell and normal cell? You know integrin and beta-adenine? Any student want to ask question?
Thank you.
A resounding thank you to all the presenters. Your work is bold, nuanced, and transformative, and embodies our theme of innovation in biomedical research and technologies for better patient care. You have set the stage ablaze. Thank you. A little pause, and then there will be a students' forum. as we are going to start. Yes, sir. Debate participants. Jaskirat Chaudhary, Suhani Sharma, Irfan Ahmed Bhatt, Yamini Sharma, Atira Imtiaz. Kindly join us.
Last.
Mayank. कौन आ रहा है? अच्छा वो वाइफ वाला कनेक्ट करता है अच्छा
चलो अब अपने से बनना तो बनो
सर उनको बुला लो
Arindam sir, Arindam sir, Karan sir.
हाँ सुन लो हाँ ठीक है आ रहे हैं कहीं एक एक ऑल्टर एक दो है दो सामने मेरे टीम से नहीं बस एक से मुझे कंफर्म नहीं अब नहीं वो तो बताएंगे आज सारा बोल रहे
Good afternoon, all present. The final and the most amazing session of day 2 of this ICBS 2025 is Students Forum. And the first event of Student Forum is debate. And we have 5 contestants for the debate. Jaskirat Chaudhary, Suhani, Irfan Ahmed Bhatt, Yamini Sharma, Atira Imtiaz. And I invite Jaskirat Chaudhary for the debate NCAHP Act 2021.
Good morning, good afternoon, judges, moderators, and my fellow participants. I am Jaskira Chaudhary. Today I am standing in front of you in strong favor of National Commission for Allied and Healthcare Professions Act 2021. India's healthcare system is more than just doctors and nurses, it's a team effort. Yet for decades, allied and healthcare professionals lacked recognition and regulation. The NCHP Act 2021 changed that. Opportunities provided by NCHP Act 2021, recognition and standardization. The Act finally gives identity and recognition to over 50 lakh allied health professionals. It sets a national framework for education, training and practice, improving quality and trust. Quality and uniformity. With the Central Commission and State Councils, it ensures standard curriculum and registration, just like doctors have the National Medical Commission. Boosts global mobility and employability. Allied healthcare professionals can now be recognized internationally and due to standardized qualification. It also increases job opportunities within India and abroad. It also covers bridges in healthcare gap. Rural and underserved areas suffer from a shortage of healthcare workers. With the help of trained allied healthcare professionals, we can bridge gaps in physiotherapy, radiology, and lab sciences, etc. In conclusion, I want to speak that NCHP Act 2021 is not just a policy, it's a step towards the dignity, strength for our allied healthcare heroes. Thank you.
Next contestant is Suhani. Suhani, please come and proceed.
Good afternoon, moderators, judges, and my fellow participants. So, today I am in strong favor of National Professionals Commission of Allied and Professional Healthcare Act 2021. Groundbreaking legislation for healthcare professionals. For decades,
Allied health professionals have been unsung heroes for our healthcare system, from physiotherapists and radiographers to occupational therapists have played a vital role in diagnosis, treatment, and rehabilitation. Until now, lab recognition, standardization, and regulatory oversight. Firstly, this act brings structure and uniformity to the education and training, covers 10 major categories of allied health professionals, create central and state regulatory framework, ensure that students across India, especially in rural areas, get proper education and quality training. Secondary, the act is a game changer for professional recognition. Allied health professional will have legal identity, professional registry, and guidelines for ethical practice. This elevates the status of healthcare system and open opportunities for career and advancement both in rural and urban areas. Third, it supports the government vision of universal health coverage and Ayushman Bharat. Implementation challenges are there, but the solution does not exist in rejection progress, but in refining it. National Commission of Allied and Healthcare Professional Act lays a strong foundation, and with proper execution, it will revolutionize the act. Conclusion is that National Commission of Allied and Healthcare Professional Act 2021 is not just a policy document, it is a promise of recognition, regulation, and state forward for healthcare for students and future. Thank you.
Next we have Yamini Sharma.
Good afternoon, everyone. We have a topic on NCAHP. It is a National Council of Allied Health Sciences, and I am on the against side, like in some drawbacks of the NCAHP. So सबसे पहले कुछ challenges हैं जो अभी भी जिन पे काम चल रहा है of the NCAHP. जैसे सबसे पहले हम implementation कुछ gaps हैं, like lack of the some infrastructures, trained faculties or resources which are the hinder rollouts. And second is the resistance to change. It's be like some existing institutions and the professionals, they have the resist standardizations, and moreover some complex registration process. It's in this thing, professionals may face the some delays or hurdles in registration or in the licensing. Something is also being like awareness and accessibility. So limited awareness is among in the rural or the unprivileged populations. Here is more things like over centralization. May ignore the some local or the state specific healthcare in which needs due to the centralized decision making. Further, some lack of clarity in the roles, like overlapping the roles with existing medical professionals may cause frictions and somewhere in the like confusions. Next is limited public awareness. Allied and healthcare professions are still poorly, not properly understood by the some areas in like of the public. Like the act doesn't adequately address in the awareness buildings. Also, some face limitations. They are like limited recognitions or some authorities in some regions
The Health Council may not have the same recognitions or authority as like a nursing or medical boards, which can limit their influence on policy or fundings. Second is scope of practice issue. These may be under or overlapping scopes of the practice among allied health professionals, leading to some professional disputes. Third is resource constraints. These organizations may face the limitations in funding, staffing. Thank you. So, some more things is like limited research or limited research and the data is there is an often lack of some comprehensive data on the contributions and the outcomes of the allied health professionals. And policy awareness is allied health goals are often not well understood by the public or even the other healthcare professions. Policy influence like NCAHP, the National Council of Allied Health Professionals, may struggle to influence the national health policies effectively, especially if allied health is not seen as a priority in healthcare reforms or in the planning. So, NCAHAP is the act which can be regulations is and the maintenance of standards of education and services which are maintenance by the central registered and state registered that in creation of a system to improve assess, research, development and adoption of the latest scientifics. Thank you.
So the next event is Techno Quiz, and for conducting Techno Quiz, I am inviting Dr. Ashwinder Rana along with Mr. Taran to conduct the Techno Quiz, sir. Sir, our participants have been in lunch, so we can wait for 5 minutes.
बेटा आप लोगों में से सबने खाना खा लिया? सबने खाना खा लिया? कोई चुप तो नहीं गया? कोई रह जाए तो जल्दी से खाना खा के आ जाइए बेटे, फिर डायरेक्टली शुरू हो जाएगा, फिर आपको टाइम नहीं मिलेगा। ओके?
कौन सी टेबल लेना है? Rules and regulations.
आया बुआरी एक्चुअली सर ने पहले सबको वैसे लंच करना, सबको लेट करना, हम तो दो लड़कों को
इनको बुला दो बात करें।
हाँ तो यही थी यार।
मेरे को चिकरा वाले को बुलाना, बाकी अपने बंदे तो आ गए।
बुला
स्कोर भी रहते हैं वो देखने के लिए, है ना?
इरफान अहमद भट्ट, यामिनी शर्मा, अतीरा इम्तियाज।
इधर बिठा दीजिए इस साइड और टीम में, है ना?
प्लीज कम फॉरवर्ड। इरफान अहमद भट्ट, यामिनी शर्मा, अतीरा इम्तियाज। सुहानी देवी, वाहिद मुस्तफा एंड मोहम्मद अहमद। Then Paramveer Singh, Jaskirat and Deepak Kumar. Paramveer Singh, Jaskirat and Deepak Kumar. I repeat, Irfan Ahmad Bhatt, Yamini Sharma, Atira Imtiaz. Irfan Ahmad Bhatt, Yamini Sharma, Atira Imtiaz.
नीचे नीचे वहाँ सामने सोफा
नीचे 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 भाई।
And one more team that consists Sakshi Bansal. Sakshi Bansal from Chitkara University.
उधर उसी हिसाब से बिठा दीजिए, 1 2 3 4 या 1 2
लॉन्च करने
10 पर लंच
फोन करो।
3 बहुत है हमारे लिए।
नहीं वो बाहर की बाहर के नंबर बताइए क्या था कुछ आपसे मतलब बोल बोलता रहे अंदर रखना है क्यों रखना वो छोटी वाली
You please call your team members till then.
आ गया सर मैम ये वो है कुछ करा हुआ है टीम 4 कहाँ
आपका टीम में
Where is your team? Yamini, your team.
मैम आपका लंच हो गया हेलो आपका लंच हो गया
given name to the committee for a quiz
क्योंकि यहाँ
competition.
स्टार्ट हो गया ओ
Where are these students? कहाँ पे है? Not
Why
present
not?
in the university.
No, I have. ये OTT वाले किधर हैं? रोज इसको बिठा के तीसरा उसी के साथ बिठा दूँ। मेरा वाला उसी।
ज़्यादा तो वैसे लैब की ये क्वेश्चन लैब की है।
इसका में कम हो रहे थे एक उसको इसके साथ बिठा दूँ। ये कौन है?
Speaker सुबह की।
स्पीकर नहीं ये नहीं है ये पार्टिसिपेंट नहीं है ये क्विज में बैठे थे नहीं मैम खाना खाने हमको बड़ी मुश्किल से जगह मिली लेकिन कुछ करा वालों तो कह रहे हम खाना नहीं खा रहे वापस आए छोड़ दें खाना नहीं खाएं
फिर रूल्स तो सब तभी बता पाएंगे जब टीम्स पूरी
हाँ अरे रखो बैग रखिए आपके बाकी तो कहाँ है
Meanwhile, if anyone among the audience is interested in having quiz competition, they can approach anyone interested in quiz, techno quiz, they can come to our teams. Anyone from the audience?
दो आ रहे हैं पता वो उसको मैं छोड़ नहीं सकती कोई चित्कारा वाले बाकी अपने तो कोई चक्कर नहीं पड़ता चित्कारा वालों का पंगा पड़ता वो जाए खाना भी नहीं खाया उसकी प्रेजेंटेशन दोनों स्कोरिंग का बताओ सर इनको
स्कोरिंग ठीक था ना आपके पास ये
Are you?
हमारे फर्स्ट राउंड में 4 क्वेश्चन गलत होगा अगर होगा +2 और नॉन +2 कुछ है
सर सिर्फ 2 स्टूडेंट्स हैं वो आ रहे हैं चिपकारा के आ रहे हैं उसके सर तभी सर बता पाएंगे सर कह रहे हैं कि प्रीमियम सुनाऊंगा
प्लस और माइनस अगर गलत बोल दिया तो माइनस
One thing on class in bracket that I was saying in 1 minute.
हाँ total 1 we have to have 1 minute
How many
in that
questions?
the total 8 questions are bracket
So
is
if
how
they are
fast
giving all 3, then 3 into 2.
हाँ exactly 1 question carries 2 राइट और रॉन्ग का मैं आपको बता दूँगा। रॉन्ग तो ठीक है, राइट है तो एक नंबर दे देंगे। लास्ट के लगेगा, लास्ट में तो वो सबकी लिखा हाँ विजुअल रहेगा। इफ द आंसर इज +2 अगर गलत दिए तो माइनस। बस कोई बस करिए अंदर ही करिए।
सुबह में से 3 बार बात की है तीनों ने, तीनों बाकी को तो मैं बुलाऊँ उसने भी डिबेट में ये किया हूँ इसको करो सर इसको ऑपरेट करने के लिए ये कर रहे हैं तो यार हम तो यार हम ज़्यादा नहीं प्रेस होना चाहिए ज़्यादा प्रेस नहीं होना चाहिए हम चुनावी बैठे हैं ये यहाँ
लास्ट में उसमें एक से 1 मिनट रखना पड़ेगा रैपिड फायर में जाने एक माडल में
चिपकाना चिपकाना
नहीं
What are you asking for?
आपका आपने नाम दिया था
नहीं ऑडियंस से भी जो आने
अच्छा
वाले
ठीक है ऑडियंस से आ रहे
सर बिठा लो मैंने
बता रहे और
मैडम मैं कहाँ से लाऊँ मुझे
यहाँ से 1 2 3 Should I start, sir? Dharam, sir? Should I start? 4 teams?
एक मिनट मैम करो करो
Good afternoon all. As our teams have arrived, so we are going to start the techno quiz, and I request Dr. Ashwinder Rana to please explain the rules for the team. Thank you.
Thank you, ma'am. So this is techno quiz, right? We have got 4 teams: team 1, team 2, team 3, team 4. All right. So we have got 3 rounds. First will be MCQ round, second will be rapid fire round, and third will be visual round, right? In the MCQ round, you have to tell the correct answer. So there will be no negative marking. So if you answer it correctly, you will get +2, right? Same in rapid fire. For the questions, you have to answer in 1 minute. The number of questions will vary depending on your how fast you answer, right? And number last visual round will show you a picture. You have to identify the picture. Fine. So these are the 3 rounds. And visual round is a buzzer round. So all the 4 teams, whoever answers fast will get the marks. But if it is a wrong answer, he will be penalized for that, right? So he will get -2 or +2. Okay. All right. So we start with the first team.
बजर
Right. So your turn. First question of team
यही
1.
कर रहे हैं सर, यही करें बैठे
So this is the manifestation of anemia results in the reduction of oxygen carrying capacity of blood, the degree of change in blood volume, the capacity of cardiovascular pulmonary system to compensate for anemia. All. Right answer. All. Right. Second question for the same team. Which of the following is the non-reducing sugar? Lactose, sucrose, glucose, galactose. Sucrose, right. Third question. Which fixed test is done for typhoid fever, typhus fever, Kala-Azar, tuberculosis? Wrong. Fourth question. Typhoid. Typhus fever. Fourth question. Which of the following is an amphoteric dye? Emetoxylin, eosin, allicin blue, and estogarmine. Wrong. Right. Team 2. First question. Blood urea is increased in all of these non-renal diseases except diabetic coma, pyloric obstruction, vomiting, severe liver disease, and burns. Burns. Wrong answer. Second. Question number 2. The agent which prevents multiplication of bacteria is called antiseptic, bactericidal, bacteriostatic, all of these. Wrong. Third, which of the following is not true for the megaloblastic anemia? Number 1, DNA synthesis is impaired, RNA synthesis is impaired, cell division is restricted, increased MCHC.
कौन जवाब दे रहे थे?
Cell division restricted. Wrong. Next question. Peroric acid acts as oxidizing agent, reducing agent, bleaching agent, none of these. And try luck this time. Oxidizing agent. Correct. Correct. No issues. Team 3. So you have the names of these teams. Team 1, Team 2, and Team 3. Yes. Alright. First question. All of the following are natural dyes except hematoxylin, eosin, indigo, litmus. Eosin, right. Question number 2 for you. Selenite broth is an enriched media used for Salmonella, Shigella, E. coli, Campylobacter. Salmonella, correct. Number 3rd question. Which of the following is not an abnormal HB? HBS, HBM, HBH, SHB. HBH, wrong. Next. Question number 4 for you. Which of these is not a fat soluble vitamin? Vitamin E, niacin, vitamin B, vitamin A. Niacin, right. Correct. Team 4. Right. Your first question. Right. The pernicious is to the deficiency of vitamin B12, folic acid, both intrinsic factor. C. Wrong. For intrinsic factor. Number 2. LCMDU method is used for demonstration of mucin, melanin, calcium, copper. Right. A, mucin, that's correct. That's already there, right? Question number 3. Which of the following is false about bacterial capsule? Number 1, protects bacteria, contribute to virulence. Loss of capsule by mutation may retain the virulence character of bacteria or demonstrated by colonization. D. Wrong. You see. Number 4. Which of the which among the following is not a primary standard? Sodium oxalate, sodium carbonate, sodium hydroxide, silver nitrate. Yeah. Sodium oxalate. Wrong. Correct. Right. Team 5. Number first. Which of the following will be demonstrated by composite state? Beta cells, delta cells, myelin, and none. What is demonstrated by composite state? Out of these. Right. None. Wrong. Beta cells. Number 2. Question number 2. Because the following finding does not show the accelerated effect of erythropoiesis in blood. Number 1. It's reticulocytosis. Erythroblastosis. Number 3. Microcytosis. And number 4. Macrocytosis. See, microcytosis is wrong, I think. This is right, okay. Right. Okay. Question number 4. Sorry. Glycosylated hemoglobin, as we can see, on concentration provides an information regarding, right? Number 1, immediate state of blood glucose level of a patient. Number 2, the average blood glucose concentration of patient over the preceding 6 to 8 weeks. And number 3, the average blood hemoglobin level of the patient over the preceding 6 to 8 weeks. The average blood hemoglobin level of patient over the preceding 6 to 8 weeks. B. That is the right answer. Number 4. Question 4. Chemical agents act in following ways in killing the microorganisms except number 1, protein coagulation, number 2, destruction of carbohydrates, number 3, destruction of cell repetition. Except. B for destruction of carbohydrate, right? That's the right answer. Okay, there. Okay, fine. Okay. This is the first round, right? Correct. So don't know who has performed what. So we can go for the next round, that is rapid fire round. So what you have to do, you have to answer in 1 minute. So the number of questions is from you, right? So we can start with the team 1. Negative marking is only in visual round.
Not in this.
You can try luck here. No, there is no problem in that. Yeah, if you don't know, you can skip the question to get the new one, right? Absolutely. Mostly from the medical sciences. You can try these. Next time we can have, from all the fields. Alright. First thing. You can start with the. Oh, these are all there. Okay, no problem. So, first question, which of the following of sterilization used for sterilizing liquid paraffin and dusting powder? Next, what is the melting point of ester wax? Wrong. Name the 3 types of lymphocytes. Next, in which organ synthesis of our urea takes place? Kidney. Wrong. Next. 1 minute you have to give. So 1. When a patient suffering from a disease and an infection is set up from external source, it's called Cross infection. Next. What is the chemical name of vitamin G? Next. So you have to say, so I will give on one question only. How many established human groups are there? Wrong. Next. What is the standard thickness of cover glass? What? Okay, fine. Team 2. So ready? Okay, let's start. Number 1. The relation between the binding and release of oxygen by Hv to 2,3-DPG is direct or inverse? Inverse, correct. Next. Cross infection occurring in hospitals are called?
Master formatting.
Your time is passing. You can say pass if you don't know. Pass. Number 3. These are nosocomial infections. Anyways, in obstructive jaundice, which type of bilirubin is increased in blood? Next. Number 4.
Salary and the shares just on this week.
Arda कैसा अच्छा क्या करो ये मसला यार अगर सब उसमें शुक्र युत तुत कष्ट गो ना क्या अच्छा अत मज खतरा अगर तेज आस गाड़ पका अल्लाह तआला ना दुम गज दौर पत मे दौर मे गथ शक दिमागस मज बहुत बार बार अमी वन अगर ड्राइवर आशा गाड़ी सह पक अनादोन तमिस पता यह जुमरी सोवरिस खतरा अगर सोवरिस आसो या सफा कोर साइडस ये तो पकान नॉर्मल पे थोड़ा तेज पक
Still no. Eh? Okay. Done? Okay. One more question. So, final question. What from APH or what? What will you saying? They are saying no, around you can ask a question. Yeah? Okay, neither from forensic nor from this, right? So I will ask my question. Correct? Okay. So you know the hemoglobin has got alpha and beta chain, right? Alpha and beta. You have to tell me the number of amino acids in alpha chain and beta chain. Right. Amino acids. Alpha and beta chain, yes. So you have to try this one. Right. Okay. No answer single one, so I will give the points. Alpha or beta. That's right. Okay, this next question, right? So both of you. Smallest bone in the body. Yeah. Okay, also both are tight, so there is no point. Okay. Next. Okay. In hemophilia A, so you know the condition hemophilia? Correct? Hemophilia is a condition. What is the factor deficient? Name the factor which is deficient in hemophilia A. Right, last one.
Oh, very good.
My last question, right? Correct? Both you are Education Minister of Punjab.
ले वो कल ही आया था चलो भाई हो गया
Okay.
चलो बेटा ना ठीक है तो ठीक है
Thank you very much, sir.
आप इधर
Good afternoon, all present. The chief guest of today's evening, Dr. Vipin Kaushal sir, is here with us. So I request the valedictory team to please take over the charge. We welcome you, sir.
A very good evening to everyone present here. We begin with the valedictory ceremony of this session. The time has come to draw a curtain to the program. A very warm welcome to the guests of the valedictory ceremony of ICBS 25. I take this opportunity to welcome our honorable chief guest, our esteemed dignitaries and participants of the conference. All participants were very enthusiastic. I am thankful to all the participants coming here to the conference. Every session has been encouraging, enriching and enlightening us and added to our academic, technical, clinical and scientific knowledge. I am sure everyone leaves from here today with new energy and new perspective on diagnostics and allied health sciences. We all welcome the chief guests of the valedictory session, Professor Dr. Vipin Kaushal, Professor and Head of Hospital Administration, Medical Superintendent and Nodal Officer Roto, PGI MER Chandigarh. A warm welcome to Dean Academic Affairs, Dr. Satish Kumar, Mr. Sahil Kapoor, Vice President Branding, RBG, Dr. Lalit Gupta, Dean USPR. I request Dr. Pankaj Kaul, Dean USAHS and Dr. Arindam Adhikari, Organizing Secretary of ICBS 25 to escort the dignitaries to the stage.
We welcome Dr. Sunil Arora, former head PGI MER Chandigarh. As a token of appreciation, we start with the flowery welcome of the guests. Dr. Shubhi Joshi would present a bouquet of flowers to Dr. Vipin Kaushal. Dr. Aprajita would present a bouquet of flowers to Dr. Satish Shah, Dean Academic Affairs. A bouquet of flowers would be presented to Dr. Arora, PGI MER Chandigarh, by Ms. Sakshi. Ms. Ibtizam to present a bouquet of flowers to Dr. Lalit, Dean USPR. Ms. Tanvi to present a bouquet of flowers to Dean US AHS Dr. Pankaj Kaul. Ms. Neha to present a bouquet of flowers to Organizing Secretary Dr. Arindam Adhikari. For the kind information of the dignitaries, the International Conference ICBS 25 comprised of various interesting, mind-blowing sessions related to interdisciplinary branches of medical laboratory sciences, forensic science, operation theatre anesthesia technology, optometry, cardiovascular technology, hospital administration, clinical embryology and reproductive genetics. The conference ICBS 25, being the first of its kind, has brought together scientists, academicians, researchers working in various fields of allied health sciences. To kickstart the event, 2 workshops covering the technical and scientific aspects of allied health were conducted at PGI MER Chandigarh and Punjab University Chandigarh. The conference was inaugurated by Professor Dr. A.K. Atri, Principal Director, GMCH 32, Chandigarh. Expert talks were delivered by Professor Shiba Kumar from Nepal, Dr. Kaptan Singh Sharawat from Kalavati Hospital, New Delhi, Professor Indu Singh from Australia Griffith University, Professor Ranjay Chaudhary, Chandigarh University, Mr. Vijay Mayer from Canada, Dr. Ashwinder Rana from PGI MER, Dr. Malkeet Singh from Dolphin College. This was followed by a Dean's Conclave. It was the organization of Dean's Conclave discussed the importance, benefits, changes, highlights of the National Education Policy 2020. In this conclave, common curriculum, NEP policy, formation of allied health sciences, National Knowledge Network for Promotion of Allied Health Sciences was one of the ideas proposed by the committee. My humble and heartfelt gratitude to the organizing committee for conducting such extensive and thorough event with unconditional, untiring enthusiasm. It is time to acknowledge the cooperation extended by RBU management and administration. The organizing committee would felicitate these integral members. So let's begin. Mr. Arun Yadav, present here. Mr. Arun Yadav will be presented by a memento.
Vipin Thakur.
Mr. Harbans Singh would be presented by a memento by Dr. Vipin Kaushal. Mr. Chamkaur Singh will be presented by a planter by Mr. Balwinder Singh, Mr. Vivek, Mr. Amit Raina, Mr. Amit, Mr. Sandeep, Mr. Varinder, Mr. Kuldeep, Mr. Kuldeep,
Raman.
Now, Dr. Shubhi Joshi, co-organizing secretary, would announce the awards of the competitions.
Mr. Binder, please come on the stage. Now the most awaited part of the conference has arrived. I know the heartbeat of the participants have increased. So we will now declare the winners of Researchers Forum and Students Forum. The prize for oral presentation award goes to, any guesses, audience? Whom? Can't hear you. The third prize for oral presentation goes to Mayank Man from Punjab University, Chandigarh. The second prize for oral presentation goes to Dr. Shamaita Basu. Any guesses who is the winner of oral presentation competition? I need a name. The first prize goes to Miss Pratibha. Now I declare the prizes for poster presentation. The third prize goes to Samana Saeed. Samana. The second prize for poster presentation goes to Ikshika Shirley. And the first prize for poster presentation goes to Anjali Tomar. Anjali. Now I would be declaring the prizes for debate competition. The third prize for debate competition goes to Yamini Sharma. The second prize for debate competition goes to Jaskirat Chaudhary. And the winner for the debate competition is Suhani Sharma. I request all the winners to come on stage. Now I will be declaring the result for the Techno quiz. We had a very good competition amongst the participants. And the first prize goes to the team Paramveer, Deepak and Jaskirat. A huge round of applause. The second prize goes to the team consisting Sakshi Bansal and Slemrin G. Slemrin. Please clap for the winners. Boost their morale, please. The third prize goes to Muhammad Ahmad Ali, Suhani and Wahid Mustafa for Techno quiz. We have received the result of winners of Best Out of Waste model also. So the first winner is Mehak from OT80, Rayat Bahara University. The second prize goes to Mehak from Cardiovascular Technology, Rayat Bahara University. The third prize goes to, I need guesses for this name. Any guesses, please? Mehak Sharma from MLS, Rayat Bahara University. Third में ये Palak Sharma MLS. Palak Sharma from MLS. आ गई सर.
So we move forward by felicitating the core committee. We begin with Dr. Arindam Adhikari, the organizing secretary. We begin by felicitating the core committee of ICBS 25. So to begin with, we have the organizing secretary, US AHS department, Dr. Arindam Adhikari. So the facilitating team will please move forward. Next will be Dr. Rita Thakur, co-organizing secretary, followed by Dr. Shubhi Joshi, co-organizing secretary. Dr. Aprajita Sharma, USAHS. Miss Lovely, USAHS. Miss Dipneet Kaur, Department Embryology. Dr. Abhishek Gupta, USAHS. Mr. Taranjeet, USAHS. Miss Sakshi Jaswal, USAHS. Mr. Taranjeet, USAHS. Dr. Ravi Ranjan Kumar. Miss Sakshi Jaswal, USAHS. Mr. Shubhashish Mukhopadhyay, USCHS. Mr. K.S. Rana, Dr. Dalbir Singh. So here we also appreciate the contribution of Dean USPR Dr. Lalit Kumar. I again announce the name of the organizing secretary, Dr. Arindam Adhikari, for such a wonderful job. With Dr. Shubhi Joshi, our co-organizing secretary, to make this event successful. We welcome Dr. Dipti to be felicitated with the memento. This is followed by felicitating the organizing committee, wishing a very happy birthday to Miss Gurpreet, the attendant in USCHS. Miss Kirandeep Kaur, Mr. Himanshu, Miss Maisara. Her award will be collected by Mr. Ishfaq, Miss Maisara,
Sapinder on Baljeet. Sapling Day.
Sapinder or Baljeet.
Mr. Baljinder.
Baljeet.
Baljeet, I request Mr. Baljeet and Mr. Sapinder to come on the stage. Mr. Himanshu, Miss Kamalpreet Kaur, Mr. Sameer, Mr. Sameer, Mr. Vaibhav Singh, Mr. Vaibhav Singh, Miss Neha Kumari, Miss Mehakpreet, Miss Tanvi Sharma, Miss Shivali, Mr. Ashwini, Miss Aditi, Miss Salpa, Mr. Asif Hussain Sheikh, Mr. Sushil Kumar Bhatt, Miss Iftizam Nasir Khan, Dr. Pyali Shom, Mr. Ishfaq Ramzan, Mr. Ashfaq Ramzan, Miss Inderjeet Kaur, Mr. Bhim Singh.
Miss Parvinder Kaur,
Next, we begin by awarding the CRs. We appreciate their contribution to the ICBS. Begin with CR Saurabh Kumar. CR Saurabh with excellent leadership qualities, always ready to serve, and always participating with humbleness. Followed by Mr. Abhishek Rana, fresh growing talent. Miss Kiranjeet Kaur, Miss Simran, all the budding talents of USAHS, please come on the stage. Miss Simran, Miss Suhani Sharma, Mr. Akib, Mr. Rohit Kumar, Miss Palak, Miss Arshita, Miss Mehak Sharma, Miss Komal, all the class representatives without whom this event would not be possible. Mr. Divyanshu, Miss Apnika Pundhir, Miss Suhani, Miss Pragati, Mr. Prathan, Miss Manpreet, Mr. Adnan, Mr. Mandeep Singh, Miss Rutpunisa, Miss Simarjot Kaur, Mr. Chanakya, Mr. Nathan, Mr. C. John Jason, Mr. Amitava Maji, Miss Ashvi Beniwal, Miss Priyanka, Miss Mehakpreet, then we have with us Miss Mehakpreet, Mr. Mrinmoy and Mr. Vivek. Mr. Vivek from IT department, faculty Miss Mehakpreet and faculty Mr. Mrinmoy. Yes, Lord. Good evening, friends. We have here with us Dr. Neena Mehta, Dean Dental Department. We appreciate her unconditional support to USAHS Department, and she is to be presented with a bouquet of flowers by our chief guest. To express a word of appreciation and gratitude, I invite Dr. Abhishek Gupta for proposing a vote of thanks. Dr. Abhishek Gupta.
an announcement for the delegates. Kindly take your certificates from the reception committee, from the reception outside.
Students, please be seated. Students, please be seated. Pratham, please take care.
Students, please be seated. You are not allowed to go. The function is not over yet. Please.
आप सभी लोग जितने भी विद्यार्थी यहाँ पर हैं, अनुशासन में जब तक वहाँ पे चीफ गेस्ट बैठे हुए, यू नीड नॉट टू लीव द ऑडिटोरियम, प्लीज सिट डाउन। दूसरी बात ये है, आप हमारे जितने आरबीयू के जितने भी सदस्य हैं, अब थोड़ा सा समय का अभाव है, तो उन सब से परिचित होंगे, लेकिन लास्ट में आदरणीय परम श्रद्धेय चिकित्सा अधीक्षक PGIMER चंडीगढ़ से आए हुए डॉक्टर विपिन कौशल का हम सभी लोग बहुत तहत मन से जोरदार तालियों से उनका स्वागत अभिनंदन करते हैं। बहुमूल्य समय में से आपको पता है PGI बहुत ही वहाँ पे एक एक मिनट एक एक सेकंड बड़ा कीमती होता है, उसमें से उन्होंने बहुमूल्य समय निकाल के अपने चरण हमारी यूनिवर्सिटी पे डाले। हम कृतज्ञ और उनके ऋणी और आभारी। बहुत बहुत धन्यवाद सर, और ऐसे ही हमें आशीर्वाद देते रहे। सर का स्वभाव बहुत सहज है, बहुत सरल है, इजीली अप्रोचेबल है, तो जब भी यहाँ से कोई कॉल जाती है प्यार में बंधे चले आते हैं। धन्यवाद सर।
We request Professor Vipin Kaushal to say a few more words of motivation for the audience. Sir, please.
Good evening all. First of all, dignitaries on the dais, off the dais, I see my friend Dr. Dalveer Singh, very senior professor in PGI, after retirement he is here. Very distinguished guests and dear delegates. I could understand in the valedictory function everybody is in a hurry to go. It's nothing new with this institution, so I will not say much, but I am thankful to Dr. Pankaj Kaur for inviting me for this valedictory function. It's really honor to be here in this university, where I could see many PGIs here. So I don't feel out of place. And this university is doing very good for the nation. And as far as this conference is concerned, where the biomedical persons are trained, I know the value of our technicians. We utmost, without them, nothing is complete. So, but as a technician, you should understand, you have to have very commitment for the work. You have to be committed, and you deal with equipment comes later. Is very important. You deal with the patients. You have to be very compassionate and empathetic while dealing with them. The way you approach them, that matters. You are going for a X-ray, you are going for a blood drive, or doing some tests, going for some anesthetic procedure. All eyes are on you. Everybody is looking to you. So communication, behavior, all important, all technical issue you are learning here in the university. But how you approach your patient and their attendant is very important. Please keep that in mind. You have to be very polite, humble while approaching the patient, taking care of. Nowadays, the AI will be coming. So you need to have the knowledge, but you need not to leave the human touch. AI will do wonders for you, but
Is your name?
it will not be human. So you need to be human. With these words, I can understand your excitement to go out. Thank you very much, organizers, for inviting me here. And really, it's a treat to come here. Wish you all the best. Delegates, do well in your all times to come. Wherever you go, prove yourself that you have learned the best practices in this university. All the best. Namaskar. Jai Hind, Jai Bharat.
All the best. Jai Hind, Jai Bharat.
Friends, we appreciate the presence of Dr. Vipin Kaushal and would present and honor him with a shield and appreciate his valuable presence in the conference. We now begin with the vote of thanks from Dr. Abhishek Gupta.
Dr. Vishesh Gupta. तो लादा नहीं का पहला तो तुम सुन ले सुना दे विश पता पर उन
Hello. Good evening, Rayabara, and good evening, all and sundry. Respected notoriety, revered faculty, dear sophomores, ladies and gentlemen, as we get closer to the dusk of yet another enlightening and enriching event, the International Conference of Biomedical Sciences 2025, I, Dr. Abhishek Gupta, stand here on behalf of the organizing committee to extend the deepest gratitude to each and every one of you who made this conference a rip-roaring colloquium. First and foremost, my heartfelt gratitude to the honorable guests on the dais. Chief guest Sir Professor Vipin Kaushal, Professor and Head Department of Hospital Administration, PGI Chandigarh. Chairman Sir, Rayat Bharat Group of Institutes. Dr. Satish Bansal, Dean Academic Affairs. Dr. Lalit Kumar Gupta, Dean USPR. Dr. Pankaj Kaushal Sir, Dean University School of Allied and Sciences. And Dr. Arindam, Organizing Secretary, USCHS. And Dr. Arora, former Head, Department of Regenerative Medicine, PGI, Chandigarh. Sirs, your presence has created an emanation of positivity for the success of this convention. Your inspiring words have truly enriched us and added immense value to this academic feast. Our many thanks to all the esteemed and distinguished guests, speakers, and the dignitaries who graced the occasion with their presence and insightful contributions. Your proficiency and enthusiasm has enhanced our understanding and inspired us to explore deeper into the domains of allied health sciences in patient care. Your invaluable insights have undoubtedly left a daunting mark on all of us present here today and helped us to justify the theme of this event, Innovations in Biomedical Research and Technologies for Better Patient Care. Many thanks to Dr. Mukesh Thakur sir, former Head and Dean, Punjabi University, Patiala, for his commitment to hold such an amazing workshop during our scientific session. Special thanks to Dr. Avneet Saini sir, Assistant Professor, Department of Biophysics, Punjabi University, Chandigarh, and Dr. Ashwinder Raina sir, Department of Histopathology, PGI, Chandigarh, for their unconditional support to hold pre-conference workshops. We extend our sincere appreciation to all the participants who have joined us from far and wide bringing with them a wealth of knowledge, experience, and perspective. Your active participation, engaging discussions, and thought-provoking questions will truly nourish the parley of this conference. We owe a debt of gratitude to our sponsors, namely Thermo Fisher Scientific and its distributor, Chlorophyll Scientific, and secondly, Bawa International Ambala, whose unwavering support and commitment have been instrumental in making this event possible. Your generosity has allowed us to create a platform for learning, networking, and collaboration that will continue to rumble for a long time to come. A special word of thanks goes to the organizing team and the preceptors of University School of Allied Health Sciences, whose consistent dedication, unconditional hard work, and meticulous planning has ensured the smooth execution of every aspect of this synod. Your tireless efforts behind the scenes have not gone unnoticed, and we are immensely grateful for your dedication and passion. Last but certainly not the least, we extend our gratitude to the branding department, Rayat Bahara University, electrical department, catering department, department of sanitation, horticulture, security, venue staff, technical support teams, information technology, maintenance, administration department, volunteers, and everyone else who has contributed in their own way, no matter how big or small, for the success of this event. International Conference of Biomedical Sciences 2025 has let us carry forward the knowledge gained, the connections made, and the inspiration ignited during these past few days. May we continue to work together towards our common goal of advancing allied health services for the ailing patients and making a positive impact on the world to provide health for all. Thanks once again to each and every one of you for your unwavering support and participation. Looking forward for the bright future of allied health professionals that lies ahead. Thank you and Jai Hind.
I now request Dean of Academic Affairs, Professor Satish Kumar, to declare the conference closed. Sir, please.
I hereby declare the conference closed.
I now request all the participants, please rise for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ